Welcome to day 2 of the National Alzheimer's Summit. We have some great discussions planned today, and I'm so glad you're joining us. I'm John Summers, the Chief Communications Officer at Us Against Alzheimer's, and today I have the privilege of speaking with Dr. Dean Ornish. Dr. Ornish is the founder of the nonprofit Preventive Medicine Research Institute in Sausalito, California. He is a clinical professor of medicine at the University of California, San Francisco, and the author of 2 books aimed at empowering people to take charge of their health through lifestyle changes. Dr. Ornish was also recently featured in a CNN special with Dr. Sanjay Gupta, where he unveiled the results of a study he and others conducted, showing that lifestyle changes can slow down and possibly even reverse the progress of dementia. Dr. Ornish joins us today to talk about that study and how the information in it can be put to use by healthcare providers and the people they see. Dr. Ornish, thank you so much for joining us today. First, can you tell us a little bit about the study?
Yes, my colleagues and I published the first randomized controlled trial showing that intensive lifestyle changes can often improve cognition and function in people who have MCI or early stage Alzheimer's disease. I think these findings are giving many people new hope and new choices that they didn't have before.
And this didn't just come out of the blue. This is something that's very similar to a study you did regarding the heart. So can you tell us a little bit more about those two and any sort of similarities that you have found between the 2 studies?
Yeah, people often say what's good for your heart is good for your brain. And it's actually bigger than that. My wife and I, Ann Ornish, co-authored a book called Undo It. And we presented a unifying theory that why is that these same lifestyle changes, a whole foods plant-based diet that's low in fat and refined carbs, moderate exercise, meditation and other yoga-based stress management techniques, and social support groups, or to reduce it to its essence, to eat well, move more, stress less, and love more. Why can these same lifestyle changes affect so many of the most common and costly chronic diseases, including both heart disease and early stage Alzheimer's? And the reason is that they're not really so different. They all share many of the same underlying biological mechanisms, things like chronic inflammation, oxidative stress, changes in the microbiome, in telomeres, in gene expression, angiogenesis, overstimulation of the sympathetic nervous system during times of chronic stress, changes in immune function, and so on. And each of these mechanisms, in turn, is directly influenced, for better and for worse, by what we eat, how we respond to stress, how much exercise we get, and how much love and support we have. And so I think our unique contribution over the last 4 decades has been using these very high-tech, expensive, state-of-the-art scientific measures to prove just how powerful these simple and low-tech and low-cost interventions can be. And because these mechanisms are so dynamic, how quickly we can often show improvement if you make big enough changes. And so beginning 4 decades ago, we showed people viewed heart disease then the way they view Alzheimer's today. In other words, back then they thought once you had heart disease, the best you could hope to accomplish was to slow down the rate at which you got worse. We showed that when people made bigger changes and a lot of things at the same time, that rather than getting worse more slowly, they actually got better and better. And so we showed for the first time that the progression of heart disease can often be reversed. And over time, that led to Medicare covering our program and making it available to the people who most need it. They created a new benefit category in 2010 to cover the same lifestyle program. And also in 4 years ago, when COVID hit, they began covering it when people do it virtually in the comfort of their own homes. So now we can reach people wherever they live. They don't have to live within driving distance of a hospital or clinic we've trained. And over the years, we found these same lifestyle changes could often reverse high blood pressure, high cholesterol, type 2 diabetes, early stage prostate cancer, a randomized trial we did with the chair of urology at UCSF, Peter Carroll, where I'm a full professor, and the then chair of urology and urologic oncology at Memorial Sloan Kettering Cancer Center in New York, Dr. Bill Fair. We found that when you change your lifestyle, it changes your gene expression. In a study we did with Craig Venter, one of the first to decode the human genome, we found that over 500 genes were changed. And in fact, turning on the genes that keep us healthy and downregulating or turning off the genes that cause us to get sick, and particularly downregulating the genes that are part of this unifying theory, the ones we talked about a moment ago, that control chronic inflammation, oxidative stress, and so on. So now we have a greater biologic plausibility of understanding why these lifestyle changes can be so powerful. We did a study with Dr. Elizabeth Blackburn, the Nobel laureate, who first pioneered the discovery of telomeres, ends of our chromosomes that regulate cellular aging. Over time, as DNA replicates, the telomeres tend to get shorter. And as our telomeres get shorter, our lives get shorter. And the risk of premature death from all of these chronic diseases that we've been mentioning, including but not limited to Alzheimer's, goes up proportionate to the degree of telomere lengthening. And Dr. Blackburn and Dr. Lissa Epple had done some pioneering studies where they found that women who were under chronic emotional stress, who had kids with autism, for example, or people who were sedentary or who smoked cigarettes, who ate junk food, their telomeres got shorter faster. And we had lunch one day, and I said, if bad things make your telomeres shorter, maybe good things make them longer. We found, sure enough, that these same lifestyle changes could increase telomerase, the enzyme that repairs and lengthens telomeres, in only 3 months, which we published in the Lancet Oncology. And over a 5-year period could actually lengthen telomeres, whereas they got shorter in the control group. This was actually the first study showing that any intervention could lengthen telomeres. And when we published this, the Lancet editors sent out a press release calling it the first study showing that lifestyle changes may reverse aging at a cellular level. So it was in that context that we designed the study to see whether these same lifestyle changes might affect the progression, slow, stop, or perhaps even reverse the progression of early stage Alzheimer's, because they share so many of the same mechanisms. That's why what's good for your heart is good for your brain. And sure enough, we found that we used 4 of the standard measures that are used in most of the FDA drug trials. The ADS-COG, the Clinical Global Impression of Change score, the Clinical Dementia Rating Sum of Boxes, and the Clinical Dementia Rating Global. And 3 of these 4 measures, we showed improvement. I should say, in all 4 measures, there were statistically significant differences. And 3 of them, and one of them was of borderline significance. If you took out an outlier, all 4 were significantly different, whereas in the control group, all 4 measures showed worsening of the disease. And if you look at one of the measures, which I think is the most clinically relevant, called the Clinical Global Impression of Change, which looks at really how Alzheimer's affects your daily function, and they also interview your spouse or caregiver, we found that 71% of the patients stopped or reversed the progression of their Alzheimer's disease in terms of improvement in cognition and function, whereas 68% of the patients in the randomized control group got worse, and none of them got better. So these findings, again, I think are really giving people hope in an area that people really need it. As you know, billions of dollars have been spent in the last 20 years to find the right drug. Only 3 have been approved in the last 20 years by the FDA. Aducanumab 3 or 4 years ago, lecanemab a year and a half ago, and more recently donanemab. And they all work by, in a sense, pulling amyloid out of your brain. And they only slow down the rate at which you get worse. And they're very expensive, up to, the newest one, donanemab, is $30,000 a person. Aducanumab was $56,000 a person, and so on, plus infusion costs and other related costs. And they have a high incidence of side effects called ARIA, including, swelling of your brain, bleeding into your brain, and so on. Now, slowing the rate of progression is good, but it's not that great because for many people it's clinically imperceptible. It's mainly in men, even though twice as many women as men get Alzheimer's, and you have these high costs and side effects. But getting worse more slowly is still getting worse. And so the suicide rate when people are diagnosed with Alzheimer's is 7 times higher than in the general population because, in a sense, they often take people's hope away. They say, I'm sorry, Mr. Jones or Ms. Smith, you've got Alzheimer's. It's only going to get worse. We can slow it down a little bit, but that's about it. Get your affairs in order. If there's anything you want to do, do it soon. You don't have a lot of time left. And so it's devastating, because when you lose your memories, you lose everything. And when you lose hope, you lose everything. I mean, I just on a personal note, I came very close to committing suicide when I was in college because I could take all the hope out of my life. I later learned that I could imbue my life with hope, just like I could take it out by doing acts of service, which is why I love doing these studies, because properly done, working with the leading scientists and physicians and as collaborators, as we've done in this study, published in a first-tier peer-reviewed journal, can redefine what's possible. And by doing so, again, we can really give people a sense of hope, not false hope. Not everybody got better in our study, but many people did. And they got better to the degree they made these lifestyle changes, which was another interesting finding. We found the more people changed, the more they adhered to this lifestyle change program, the more they improved at any age. And we also looked at some biomarkers like amyloid, like the A-beta 42/40 ratio, which is a measure of amyloid. So one of the most important biomarkers is called the A-beta 42/40 ratio, and it's a measure of amyloid in the brain. The drug trials work by, in effect, pulling amyloid out of your brain so your blood levels go up. And that's what we found in the patients in this study too. It was significantly different compared to the control group, which their levels actually went down, presumably more amyloid went into their brain. And not only that, but it was in direct proportion to the degree of a lifestyle change. And I think the reason why the lifestyle changes are showing a bigger impact than the drugs is that the drugs are focusing mainly on amyloid. And amyloid is one, but not is only one of the many mechanisms that affect Alzheimer's, just as we've talked about earlier, these mechanisms that affect so many chronic diseases. So by targeting that one measure, you get some benefit. It slows it down a bit. But we also found the lifestyle changes also have the same effect on the amyloid, but also affect these other mechanisms as well. And that's why we're able to show, in many cases, improvement in cognition and function rather than just slowing down the rate at which people get worse.
Thank you. I think one thing that's important for the audience to understand and maybe get a little more insight from you on with respect to the study is I think a lot of us have known, and it's been out there, and there's lots of data to support it, that there are things that people can do in their daily lives to reduce their risk of developing Alzheimer's, dementia, or slowing down its progression. But what you're talking about, what you did in your study, is definitely more intensive, right? It wasn't just a matter of taking a 30-minute walk a day, and it wasn't just a matter of eating more fruits and vegetables. It was a more intensive program. Can you give us sort of a glimpse into that?
Yeah, that's a really good question. It's kind of like the old saying, ounce of prevention, pound of cure. And the reason why we were the first to show that lifestyle changes could often reverse the progression of so many chronic diseases is that it's really hard. You have to make really big changes to reverse a chronic disease that you've already got. And the same as we found here, we actually correlated the degree of lifestyle change that was required in our study to get to stop or improve cognition and function. It was a lot. It ranged from 74% to even a little more than 100% in one of the measures. And so if you're trying to prevent disease, you don't have to make such big changes. And I think, one of the reasons why the study has implications for prevention is that, with some of the new artificial intelligence enhanced technologies, it may be possible to predict someone who's going to get Alzheimer's, up to 10 years before it becomes clinically apparent. But until now, a lot of people would say, why would I want to know if I'm likely to get something that I can't do anything about? But if we can often improve cognition and function if people have it, it probably works even better to prevent it, and you don't probably have to make such big changes. To get reversal, we ask people to follow essentially a vegan diet: fruits, vegetables, whole grains, legumes, and soy products, minimally processed, as close as possible to what comes in nature, also low in fat and low in sugar and refined carbs. To do an hour a day of yoga and meditation, stretching, breathing, meditation, and so on. To do at least a half hour a day or an hour 3 times a week of aerobic and strength training exercise, and to participate in a support group 3 times a week. Now that's a lot, but unlike the drugs, which are expensive and have really bad side effects, the only side effects of these lifestyle changes are good ones. Your heart, your diabetes, your blood pressure, your weight, all these other things get better over time.
For people who have concerns about the level of intensity, because it is a very involved program, as you just described, but one that clearly seems to be effective. But for people who maybe aren't able to do that, what do you say to them? Is it all or nothing, or is something worth at least a little? What are your thoughts on that for people who may not be able to do that level of intensity?
Well, in all all 4 decades of doing these studies, we found that the more you change, the more you improve at any age. But to get reversal of disease, it takes really big changes. Again, that's why we were the first to show that, as most people didn't go far enough. Now, a lot of it depends on your question actually kind of implies like, well, surely people can't do this. But, we have data on over 15,000 people who've been able to do this. We've actually measured outcomes on over the years. And a lot of it has to do with how you present it to someone. If you say, certainly you wouldn't be able to make lifestyle changes to this degree, and why would you want to anyway? Just take this statin for heart disease, or take this, lecanemab for Alzheimer's disease, and that'll do it. And the patient doesn't change, and they say, see, I knew you couldn't do it. But if you say to them, look, we're here to support you. That's why Medicare is covering our program since 2010, is because 93% of the people who start our program finish all 72 hours. Medicare is paying for 4 hours twice a week for 9 weeks to give people the support and the information they need to make these changes. And 93% of the people who started complete it. Now, that's unheard of. I mean, to put that in context, you would think that taking a pill like a statin to lower your cholesterol is easy and everybody will do it, and changing lifestyle is difficult, if not impossible. But it turns out that two-thirds of the people who are prescribed statins are not taking them just a couple of months later because, and they're of proven value, and they usually don't have many side effects, and usually someone else is paying for it. So why is that? And the answer is over the 4 decades, we've really learned what really motivates people to make sustainable changes in lifestyle. And it's not the way I was trained. I was trained to try to scare people, fear. Put that cheeseburger down, you're gonna get a heart attack. Put that cigarette down, you're gonna get lung cancer. And fear is not a sustainable motivator. I mean, for a month or so after you've had a heart attack or a diagnosis of Alzheimer's, people do pretty much anything, but not for very long because we all know we're going to die. The mortality rate is still 100%, but we don't think about it most of the time, except when something happens. And even then, the denial comes back a month or two later. But what is sustainable is joy and love and pleasure and feeling good. And because these biological mechanisms that we talked about earlier are so dynamic, people think that small gradual changes are easy and big rapid changes are hard. But sometimes it's actually the other way around. Because when you make big changes, you feel so much better so quickly. Like in the case of someone with heart disease, their chest pain may go away. Or in the case of someone with Alzheimer's, within 12 weeks or so, or 14, 16 weeks, they start to remember things. Oh, I can read a book again. I used to forget the plot. I couldn't watch a movie. I couldn't, keep track of the characters. Now I can do that. I couldn't do my checkbook at home. A CFO, couldn't even do his own checkbook. Now he's able to do that. Or it took him a month to read a book. Now he can do one in 2 or 3 days. And so for many people, there are choices worth making, not to prevent something bad from happening years down the road, which is hard to stay motivated for, but that what you gain is so much more than what you give up. And people say things like, I like eating junk food, but not that much because I like not having chest pain. If they have heart disease, I can make love with my spouse. I can play with my kids. I can go back to work. I can do all the things that I couldn't do before. So the choices are worth making, not just to prevent something bad, but because what you gain is so much more than what you give up and how quickly that can occur.
Thank you. One of the things that I noticed is that it was a smaller group in this study, right? About 24 people who you had participate in the study, but a lot of them were Caucasian. So I wanted to find out from you what the thinking was behind that. Was it difficult recruiting people of color to become part of this? Because as you know, Black and Latino people in particular are really hit hard by this disease. So I'd love to hear more about what you're doing in terms of increasing the representation of Black and Latino people as this study continues, if it's continuing.
Yeah, no, it's an important question. First of all, it wasn't 24, it was over 4 dozen. We had 51 people in the study. And there's two aspects. One is the efficacy and the other is the generalizability. So let's talk about both, but let's start with your question, which is really the generalizability. We put a lot of effort into recruiting a diverse group of people as possible. We talked with a number of African-American neurologists and neurosurgeons. We went to barbershops. We had direct mail campaigns. We did everything we could, but we didn't get as many as we hoped. It's just unfortunate. And in fact, we didn't get as many total participants as we hoped, in part because COVID happened in the middle of the study, in part because the pharma companies are also recruiting the same patients who have early stage Alzheimer's because they know that's where you're most likely to show improvement. But they'll pay up to $50,000 for every patient who enrolls. We can't do that. So we ended up with fewer patients. On the other hand, from an efficacy standpoint, if you show statistically significant differences in a smaller group of people, it's equally valid. In fact, in some ways, it just shows that your intervention is that much more potent to be able to detect a statistically significant difference in a smaller sample. By analogy, if you were looking at the effects of penicillin on pneumococcal pneumonia back in 1950, before there was drug resistance, and you had 51 patients, and half of them you gave penicillin and half of them you didn't, you don't need 1,000 people to know that it's actually working.
A big part of our audience that's watching today are healthcare providers. How can they take the information that you've learned, what you're sharing with us today, and apply it to their own practice as they work with individuals?
Yeah, well, just spending a few minutes with people and letting them know that this is worth doing can give people a sense of hope. Hope is powerful. You know, when you take someone's hope away, which is often the case, if you tell people it's only going to get worse, it almost becomes self-fulfilling in a way. I mean, your world starts to shrink. That, I'm sorry you can't. We have to take your driver's license away, and don't go out by yourself, and all those kinds of things. And so it's almost like the brain starts to shut down as an adaptive response to such terrible news. And so I think part of the value of our program, of our study, was to give people, again, there's no guarantees. Not everybody gets better, but a lot of people do to the degree they make these changes. And so I think one of the best things that a doctor can do is to give their patients a sense of hope. Our $15 Undo It book, our PMRI.org, our nonprofit website, has all the information on how people can make these changes. We're also starting to make it available to people. Medicare has been covering our program, the same exact program for people with heart disease since 2010. And we're getting bigger changes in lifestyle, better clinical outcomes, bigger cost savings, better adherence, better clinical engagement than people have ever shown before. And we're already in discussions with CMS. Would they broaden the coverage to include those who have early stage Alzheimer's disease? Again, it's exactly the same program they're already covering. All they have to do is broaden the inclusion criteria. And so that process will likely take a year or so to go through what's called a national coverage determination. But we're working to try to make this available to people because we've seen what a powerful difference it can make. And even, with what Medicare is reimbursing, it's a fraction of what the drugs cost, and it works even better with only good side effects. So just as a doctor, letting people know that there is hope if they are willing to make these changes. And these are changes that many people are able to do on their own. And those who need more support, we're working to be able to try to make that financially affordable for people.
Dr. Ornish, it's an incredible study. Loved learning so much more about it and really appreciate you taking the time to join us today. So thank you so much.
Well, thank you. And it may be as drugs get better, the like with heart disease, combining the best of drugs and the best of lifestyle may give people the most powerful impact. To me, awareness is the first step in healing. And I so appreciate the chance to raise awareness and let people know that they often have choices that they might not have had before.
Absolutely. Well, thank you again for being with us today. Really appreciate it.
Thank you.
Women are 2/3 of the diagnosed and undiagnosed cases of Alzheimer's. It's important for us to lift up our voices. I was chancellor of the University of Denver. I was getting an award for starting the Center on Healthy Aging. I stood up that night to accept the award, and I announced I had Alzheimer's. I hadn't said it publicly. When I made that announcement, a hush fell over the room, and spontaneously, everyone stood up and started applauding and shouting. I've had a long career. I've been very successful. But none of that has been empowering as fighting against this disease. And one of the most important ways that you can fight against this disease is to join us against Alzheimer's. Be a part of this enormous community that's having a real impact.
Hello, my name is Natasha Gassenbach, and I am the Head of Global Corporate Affairs at Biogen. We are proud and honored to be a sponsor of this year's National Alzheimer's Summit. Thank you to our friends and colleagues at Us Against Alzheimer's for all you do in the fight against Alzheimer's disease. This year's summit, the new era of Alzheimer's, what does it mean for all of us, is incredibly timely. The last 5 years have opened a new era, and we have witnessed remarkable breakthrough and advancement in Alzheimer's research and therapy. Now, we must focus on the vital task of ensuring that those who need it most, the patients, their families, and their communities, have the chance to learn about and benefit from this advancement. Us Against Alzheimer's, remarkable efforts, advancing early detection and diagnosis, championing health equity, advocating for increased research funding, and pushing for policy changes are essentials for driving the progress that truly impacts families and communities affected by this disease. On behalf of the team at Biogen, we are truly proud to stand by your mission and work side by side with you. Finally, I'd like to warmly welcome all the attendees at today's summit. Tackling a complex health challenge like Alzheimer's disease requires all of us to collaborate. We have entered a new era. Let's keep the momentum going. Thank you.
Ladies and gentlemen, Chair and co-founder of Us Against Alzheimer's, George Vredenberg.
Congressman LaHood from the great state of Illinois, a member of the Ways and Means Committee, a champion for Alzheimer's policies here in Congress. Thank you for spending a few minutes with us this afternoon.
George, great to be with you, and thanks for all you do in this space. I've enjoyed working with you and your team as we continue our goal of finding a cure for Alzheimer's.
That's the goal. You were the champion of what we call the Change Act, which stands for something we make up, a lot of these words, but it basically would require an objective assessment of cognitive impairment at the Welcome to Medicare visit and in the annual Medicare visit. What do you think is important about early detection of this disease?
Well, the Change Act reflects what we want to do in law, and that's early detection. You hit on this. It's so vitally important that we have early detection for anybody across the country. And unfortunately, we've been very deficient in that. And so what our bill does is looks at ways to make sure that everybody can have that diagnosis. And we were very happy that our bill passed through the Ways and Means Committee early this year in a bipartisan way. And so that was due to a lot of work and progress to get that done. But what this will do is, again, put into law and codify the ability to have that early detection. Because what we've seen by the research and the studies, that when you have that early detection, you can get treatment quicker, we can get diagnosis quicker, and we can help people as they, whether it's caregivers or patients or families, to deal with this.
That's exactly right. You don't want to diagnose cancer at stage 4, stage 1. That's what we need to do with Alzheimer's, and you're a champion of that. So what are the prospects of this bill getting done this year?
Yeah, so we've made progress, obviously, getting it through the committee process. I was proud to champion that along with lots of others on the Ways and Means Committee. And so we're able to get it passed, get it through the House. And so what we hope is that the Senate will take it up in the lame duck session, and then we can get it passed into law. As you know, George, after the election, we'll have a lame duck session in end of November and December. There'll be a lot going on then. We think this is perfect to get passed into law. There's nobody, in my view, or that I've detected, that is against this legislation. And so it's just a matter of finding that vehicle to get it done. But we're going to continue to push, continue to advocate, continue to educate our members in the House and Senate to get this across the finish line.
Well, we noticed that the reauthorization of the National Alzheimer's Project Act, which has really driven research levels of investment over the last 10, 12 years, just passed the House. Thank you very much. Absolutely no objection in the House. Suspension calendar, meaning no one had an objection to the passage of that act. Hopefully we can do the same thing with the Change Act and the lame duck.
That's the goal, absolutely.
Do you have a correspondent in the Senate with whom you talk about this?
There's a number of senators that we've worked with on this. Senator Cassidy has been one that's been a strong advocate over there. Obviously, he's a physician by trade, and so he's been a wonderful partner and advocate on a number of our Alzheimer's related bills.
Yep, he's the leader of the cause over there. We know him well, so we will make sure that he passes your law.
That would be great, George.
We call it the Hood Act then. Tell me, NIH funding, you have been a real champion of funding NIH, largest funder of research in the world. And it is one of those jewels of the American crown, so to speak, in terms of the admiration of the rest of the world with respect to the NIH. It is receiving bipartisan support. Now, obviously, the levels of funding is always a little issue, but why do you think NIH is so important?
Well, if you look at what NIH has done for this country, it's really remarkable, George. And sometimes our constituents don't always understand that. But when I go back to my district and talk to my 750,000 constituents in district, I always, first of all, explain to them what NIH is, National Institutes of Health, but then describe to them the researchers there, the PhDs, the physicians that are there working on tremendous research. Alzheimer's research, cancer research, heart disease, mental health disease, all of these things that unfortunately afflict the United States and many of our citizens here. And so when I look at the amount of money that we've spent through taxpayer appropriations, I've seen the value that's come back to the United States in terms of what that research has done to help reduce many of those many of those diseases, and the statistics bear that out. So I think this is money that has been a good investment. Now, you mentioned about, does it still have bipartisanship? It should, George. But as you know, the debt and deficit comes into a lot of our conversations. We're $35 trillion in debt. We need to be acutely focused on our debt. That's a big part of our job, is making sure we meet a budget. So that complicates it a little bit. But again, I think if you look at the value we've gotten from NIH, and I think Alzheimer's is a good example of that in terms of the progress we've made, statistics bear that out. Again, it's a wise use of taxpayer money to do that. So we saw that obviously during COVID, the investment we made in NIH that had real results for the American people on getting us through the pandemic. So I'm going to continue to be a strong advocate for NIH funding, particularly in the Alzheimer's space. And my gut tells me that when members of Congress are educated on this and they understand the results and the positive medical results that we've had, I think they'll be on board with it. But it's always a challenge when you have a debt and deficit like we do.
Well, one of the great challenges of Alzheimer's is how much it costs Medicare and Medicaid to take care of individuals with the disease and support their families. And of course, family costs are significant and growing as well as you go through the course of this disease. So we are, in a sense, this is an issue you've championed, is that in fact, in order to reduce the burden on Medicare and Medicaid of Alzheimer's care spending, we need a cure. So that in fact, investment in NIH is not only smart for research purposes, it's smart to actually get at the problems that are causing increases in Medicare spending. So,
well, again, to your point, I think it's a very good point, George. We're saving taxpayer money in the long run by investing in this now through NIH and that research. That's ultimately and we've seen that in other things we've done, other examples, but clearly investing this money in NIH for Alzheimer's research is going to pay dividends, because as we have an aging population, obviously, the cost associated with dementia and Alzheimer's when it's too late is going to cost taxpayers a lot of money in the end.
let me ask you how it is that we ought to assure ourselves that the money at NIH in Alzheimer's research and in other areas is well spent. How do you, as a congressman and a leading figure in the Alzheimer's field, and others as well, assure yourself, how do I make sure that the NIH is investing this money well?
Well, I think part of our role in Congress is oversight, making sure every nickel and dime of taxpayer money is spent wisely. And I think what you always have to look at, this applies to NIH, but other federal programs, making sure the money is spent efficiently, effectively, and accountable. In our oversight role on the Ways and Means Committee, we make sure that those dollars are going to the appropriate places, being spent the right way, is not being wasted. And again, that we look at metrics, we look at results, and I think we've seen some real positive results on that. So it's getting that information to the members of Congress that maybe don't look at it the way that we do in our proper oversight role, but reminding them of the dividends that have been paid and how we're saving taxpayer money in the long run.
Well, it's interesting. The reauthorization of the National Alzheimer's Project Act came along with a reauthorization of the professional judgment budgets. These are budgets that are sent to you independently of the general budget, but a professional judgment on the part of the NIH about how much money is needed in order to achieve the goal of preventing and treating Alzheimer's by 2025. Now we've extended our goal to 2035. It will be an interesting conversation that we have started now with HHS and with NIH about exactly what we ought to set as a 2035 goal. Because we've made progress, as you mentioned, significant progress on Alzheimer's as a result of the funding increases that you have been such a champion of up to 2025. But we're almost there. So what do we do for the next 10 years?
Well, we build on our success, George. We build on the success we've had for 2025, as you alluded to. And again, showing the American people, but also my fellow members of Congress, the progress we have made. And as you know, George, every family has been touched in some way by Alzheimer's, by dementia, by this terrible disease. Many members of Congress have seen it, but we've also seen the progress that have been made, that there is hope out there, and continuing to give caregivers and families and loved ones that hope, which we've seen with 2025 is important. So as we look at 2035 and our goals that we have there, I think it's building off that success and continuing to ramp that up at a level that we've never seen before. That's really what we need to do. And that's what we're all engaged in. And I look forward to continuing to be part of that.
Great. You mentioned the success. We have 2 new disease-modifying drugs. And last year, there was some real concern because Medicare was signaling that it wasn't going to cover those drugs. And you were a real champion in moving Medicare to a position almost perfectly of getting coverage for those drugs. And so it is a real testimony to the power of Congress to express its views to a government agency to say this is important. So just walk through what you did last year. And I'll mention on the way to that is that our polling during that fight last year is that half of American voters, half of American adults know someone in their family or a close friend who have had this disease. So to your point about how many millions of Americans, hundreds of millions of Americans feel this disease intimately. So thank you for your championship, but I'm curious as to how you thought about the Medicare coverage issue.
Yeah, George, you mentioned 2 really life-changing drugs that have come into the space that were approved by FDA and going through the clinical processes, which they should. But we met some resistance from CMS related to those FDA-approved drugs. And so we need to push government agencies when we don't believe they're looking at the right information or making the right decisions. And with such a need for getting these drugs into the market and getting to patients, we were very, very frustrated in a bipartisan way by CMS not moving forward. And so we wrote a letter. I think we had 75 members of Congress in a bipartisan way.
Yes.
I led that effort along with a number of my colleagues to do that and laid out in there the justification and the reasoning for why they've made the wrong decision there. Luckily, they made the right decision. They reversed themselves on that. And now we have those 2 drugs that are being utilized in the market now. And we need to make sure that as many people that want access to them can have access to them. But again, it was a way for us to exercise our power and our objective to be involved in this space. And I would just say, George, we laid out in detail the evidence and the research on why we thought this was appropriate, and they reached the right conclusion.
Well, it wasn't a matter of luck. It was a matter of the will of Congress, because I think in the aggregate of 535 members of Congress, over 1/3 expressed their point of view. And you were a leader to half of that coalition. So we have to thank you for that effort, because otherwise it's only private pay. Otherwise, only the wealthy and high-income middle class can get access to these drugs, but you made them available for all. So thank you for that. And I want to thank you so very much for continuing to be a champion in this space. It's important to the American people, and you're leading bipartisan efforts on this, where you find Democrats who are willing to come to the same place that you are, and you to their part. And this is one of the great strengths I think the Alzheimer's movement has had, is that this has always been bipartisan, always been bipartisan.
Well, thanks for that, George. And I'm passionate about this. Having family members of my own that have been affected, I've seen it firsthand. But also being able to be a leader in this space and continue to move forward in a bipartisan way on the Ways and Means Committee and with a number of my other colleagues is important. Again, seeing what we've done already and the progress we've made and the lives we've saved and the families we've helped and the caregivers we're making to have a better way of life, we can only improve upon those things. And so as long as I'm in the job, I look forward to continuing to be a partner with you, George, and the team and this effort against Alzheimer's.
Thank you, Congressman.
Thank you, George.
You take care.
You too.
Thanks for being with us today.
Thank you.
Thank you, George and Congressman LaHood. After the break, our next panel will discuss the need for an effective biomarker strategy that works in diverse, real-world populations. That's coming up at 2 o'clock Eastern.
The Business Collaborative for Brain Health is an alliance of leading companies and organizations who understand that improving brain health and brain health skills is not only good for people, but it's good for business. Our founding partners include organizations like GN Group, AARP, Novo Nordisk, Eli Lilly. They understand there's power in a collaborative, that sharing information and learning from, in some cases, their competitors, but also from experts about what actually works to develop a brain healthy workplace is a really valuable asset that can drive their business. Businesses are run by people and people are run by their brains. So investing in brain health is investing in your company. Well-being programs have traditionally been thought of as an employee benefit, as opposed to a key investment in your business itself. If we're in a knowledge economy and the asset ledger is human beings, then we have to invest in human beings, and human beings are run by their brains.
I'm Ann Staunton Adams, and I am the individual giving officer for Us Against Alzheimer's. Alzheimer's has really affected my family. It's affected my grandmother, my father, my mother, all in very different ways, and they've had very different journeys with the disease. For women, Alzheimer's is a greater burden. Women are twice as likely to be impacted by Alzheimer's or dementia. Women are more likely to be caregivers. One of the things I learned as a caregiver is that it's okay to ask for help, that it's okay to have a bad day and to make a mistake. You're allowed to forgive yourself for getting it wrong. It's okay to take some time off, to take a minute, to ask someone to share the burden so you can have a moment to recharge.
There are all types of advocacy. The A-list is personal. The A-list is a comprehensive survey of people living with the disease that share what matters most to them. For those on the Alzheimer's journey, it is their way of telling the world how they feel and having their voice melded with others who feel exactly the same way. When caregivers get together, we share stories or experiences, but where the real power comes in is if you take those experiences and turn it into data. Data talks in a way that no individual voice can be heard. We need people to join the A-list. We want them to feel empowered. Test it, try it. And we respect your time because the surveys are short. After all, they're being written by people who understand the disease, who've lived the disease. If you feel that you haven't been heard, the A-list is a solution.
Not all brains are the same. This panel will explore how experts evaluate blood biomarker accuracy in diverse real-world populations, including individuals of different races and ethnicities, and those with comorbidities that may affect readings or symptom severity. We'll discuss how doctors communicate these results and assess whether we're ready to implement these diagnostics across all populations. The question is, are we ready? Dr. Neelam Agarwal of Rush University leads that discussion.
Hello, everyone. I would like to welcome you to today's summit. Today's topic is implementation of an effective and inclusive biomarker strategy. I am Neelam Agarwal, and I'm a professor in the Department of Neurological Sciences at the Rush Alzheimer's Disease Center in Chicago. And I will serve as today's moderator. And I'd like to also introduce our panelists for today's discussion. Dr. Sue Borson is a clinical professor at the USC Keck School of Medicine. Dr. Sid O'Brien is a professor in the Family Medicine and Osteopathic Manipulative Medicine at the Texas College of Osteopathic Medicine at the University of North Texas. And Dr. Chi Uday Momo is a neuroscientist at the Wake Forest University and Aga Khan University in Kenya. So I'd like to welcome all of my panelists today. I am so excited to have you here so that we can have a conversation about this very, very, very important topic. Before we start our conversation, I do want to frame this discussion a little bit and really talk about this important issue of blood biomarkers and tests and how they could be used in clinical settings. Now, we've all heard the media and the news about these recent advances in the use of potential uses of these tests, and simply that these tests have been touted to perhaps make the diagnosis of Alzheimer's disease easier, faster, and potentially have more people come into a treatment modality when it comes to getting disease-modifying therapy. The question that comes up, though, however, is this really what's happening? And is this really what we're going to actually see roll out in the future? Concerns come with infrastructure. Are we ready to handle this kind of testing? Education, not only for physicians that will be asked by their patients about these tests, but their whole healthcare teams. It's not just a physician, it's a team of workers. And importantly, the patients and families and their expectations for these kinds of tests. The other issues that are coming up is how are we going to implement this whole test into the general scheme of how we work now? And how does that have the potential to change how we are going to work in the future? So we have a lot of things to discuss. We have a lot of things to unpack in this discussion, and I know my panelists are just waiting to get started. So I'm going to start off with Sue. We talked about this before, and I really would like to hear your thoughts, Sue, on these tests, these markers. What are your experiences right now as these are emerging, and what are your concerns?
Thank you very much. So the tests are getting better and better and better, meaning they're getting much more accurate in in depicting the likelihood that somebody actually has Alzheimer type pathology in their brain. So that at the technical level, blood-based biomarkers are just improving kind of apace. They are not currently generally covered by insurance plans. So that's one threshold that hasn't yet been crossed. But the question that I have mostly about them is the idea of diagnosing Alzheimer's disease pathology at a very early stage is most relevant when you're in a system that can provide biological therapies to alter, that we hope will alter the course. And most healthcare systems are not equipped to do that now. So should they be? That's a kind of an ethical question, and it's an economic question about how we spend our precious healthcare dollars. So I think I'm just opening these topics as potential concerns. And I want to make one more comment before we hear from everyone else, and that is that you can't use blood-based biomarkers as population screening tools. This is the wrong idea. Somehow I think people do have the idea that a simple blood test, we can test everybody in my clinical practice or in my healthcare system with a blood-based biomarker, and we're going to know the prevalence of Alzheimer's disease. And that, I think, is a flawed bit of reasoning, and one that should be discouraged. It's not the right way to think about the problem.
And Sue, before I go to Sid, you're bringing this up. So that means these discussions are occurring right now. You're hearing them, right? You're hearing them in the hallways. You're hearing them from even providers, I'm sure.
Yes.
Like, hey, let's just do that. So Sid, why don't you, jump in here and what your thoughts are, and Sue's really good points that she's bringing up.
Yeah, I mean, these bring up, there's a lot of considerations that really need to be hammered out before we can just say, let's run with these things. As Sue pointed out, the blood test, it seems like each year the analytics, so just the technical aspects of the blood test seem to be improving. And that is a huge, huge thing for the field, which I'm ecstatic to see. I don't think the field has been thinking through some of the implications of this. And so, for example, the population screening component, even from a reimbursement standpoint, there are almost no tests in the medical system that are just broadly used for screening. So it's, what are you going to do with this information? And so for me, in that primary care level, it's how exactly are we helping these frontline clinicians, whether it's physician, whether it's a nurse practitioner, PA, whomever, because the patients have real concerns and real problems. And how are we advancing these individuals to the appropriate next steps? Because these frontline tools should be used as a means of saying, okay, you don't need something else. And we can cut down costs, cut down anxiety. And then obviously for me, one of the biggest concerns I have is just a complete lack of representation in the research for these. Our studies are very clearly showing that these markers are impacted by different, race and ethnicity, communities, medical comorbidities. There's a lot of promise there, and I'm very excited. I also am cautious that I want to make sure when we're really rolling these out, we're doing so in a manner that best helps our communities and our patients.
Yeah, well said. So Chi, what are your thoughts?
Yeah, I mean, these are really excellent points. Absolutely, Sue and Sid. I fully agree. Incidentally, a couple of days ago, a publication on recommendations for the clinical implementation of blood biomarkers, was published online. And so we convened a group, the Global COI, and we really discussed, we thought long and hard about how it can be clinically implemented. Some of the cost considerations for this, including ethical considerations, that both Sue and Sid have alluded to. So I think our recommendations really, and this represents the viewpoint of this large consortium, was really around the fact that, at this stage particularly, blood biomarkers could be used primarily for ruling out non-AD causes of cognitive impairment. And quite critically as well, we think that its utility at present time as well, despite, of course, Sid mentioned, and it's quite true, the innovations in terms of the diagnostic performance of these blood tests, they're rivaling, the CSF test, the PET test. But then again, with blood tests, they're impacted by comorbidities. They're impacted by racial and other influences. So we think that they could serve as a trial tool right now for further confirmatory testing, like PET scans and lumbar punctures. So I'm encouraged by how promising, these tests are and the advances in terms of their technological capabilities. But I still think, there's such a huge need for further validation in diverse populations. And that's what, and I'm not just talking of ethnically diverse populations, I'm talking of socioeconomically diverse populations, even including other communities like transgender diverse. I mean, I could go on and on, but you get what I mean. There's such a huge need to see the diagnostic accuracy across all these groups, because I think it'll really impact how we interpret the results as well.
Yeah, I think, listening to all of you, and my concern has always been, you it's not that hard to order a test. Anyone who does it, it's like 5 minutes. You order the test. It's always for me the now what? The
Right,
now what?
right.
So, okay, you get it back and it's now sitting in your lap, that test, whoever ordered that test, and it may be indeterminate. Now what? You have all these other pieces that have gone on with this patient and family. How are we going to fold all this in? And how are we going to think about that? I mean, you can say this is one piece of the puzzle, if you will, of what's happening. But a lot of times expectations for patients and families are very different. Like, this is it. This is it. So, let's talk, Sid. How have you approached these issues? Because I'm sure they've come up already. I'm sure that they have landed in your lap. I mean, just give us some ideas of how you've approached this, because it's going to happen as we get into more different populations that are going to be having these tests done.
This is a real issue, and especially when you think at that primary care level, because the vast majority of patients with Alzheimer's or concerns with Alzheimer's, they're seeing primary care docs, and many of them never get referred because of lack of access to specialists. And so that primary care doc, whoever that frontline person is, they get these results, and given base rates, the whole point of a rule out test in primary care is to ease those concerns, because we know 15%, 65 and above would be a high end of Alzheimer's. That rule out component is so important for those doctors, because then they can look at other causes, right? That indeterminate is where, and I've had discussions with primary care docs, I've had discussions with community patients who have had this, and it's almost as if that's like the worst case scenario, because they're still sitting in limbo, right? And so I think we don't have clear systems in place, because some of these tests, actually, you could do even a multi-tiered blood test to get rapid results, because a large scale rule out is not going to have the rule inaccuracy. But some of these blood tests could even be a second step. We have to educate families, though. We have to educate the providers, because as a clinician, when you're sitting there with someone and now you're saying, hey, we think you may have Alzheimer's disease, that's not the end of the story. And so these indeterminate components, many of these people and patients and even providers don't have access to PET scans, or their insurance won't cover it. And so we have to think very carefully of how we're going to get through that. And I think there's very clear paths of how we can. But right now, we have people come in our research where they were in that level. And that's one of the reasons they got referred, because they can get these scans for free. And, community members, and all I can tell them oftentimes is, be patient, let's get additional work. But oftentimes the primary care docs are sitting there going, I've had a primary care doc tell me, he goes, I don't want this test again. I don't want it, because I've had so many indeterminates that it's a waste of money, and a waste. It's hurting my patients. And we got to do better with that one.
Well, I'm going to ask Sue the same question, but I can tell you that time to discuss and counsel, oh my goodness, anyone who's worked in a very busy clinic situation, who has that time? And then more importantly, the question always comes, who's reimbursing for that time? It always does. It does unfortunately come down to a reimbursement issue, right? So a lot of times things get sideswept. But Sue, what do you think about, what Sid is talking about, these indeterminates, and how to handle this when this comes back, and what are we going to do? I mean, what have you seen? And what are your concerns about the trajectory of somebody or a patient's journey of how that's going to end or start, or what do you think?
I'd like even to take a step further back about this, that and focus on the fact that there's been a move toward defining positive biomarker positivity as definitive, a defining condition of Alzheimer's disease. In other words, if you have an Alzheimer molecular biomarker, you have Alzheimer's disease. And I think that's a bit of a tricky issue in the first place. Why? Because a disease usually is something that affects a person. And so we know that there are plenty of people who would be considered at risk for or at higher than average risk of Alzheimer's disease because they have biomarker positivity. But many of them will never go on to have significant cognitive impairment. And given that, I think many of us question this whole equation of biomarker positivity with the presence of disease, as opposed to this is a marker of risk for cognitive decline of the Alzheimer type. And markers of risk are things that are very hard for people to process. It's hard for, we don't have a calculator like the vascular, heart attack calculators that have come from decades of research. We don't have a calculator to tell people this is the likelihood that you and your individual self have this much risk of developing dementia of the Alzheimer type within X years. And I think that is for me, that's the standard that I want to push the field toward if I have anything to say about it. Because I don't think that primary care docs should be screening their patients willy-nilly. I think I want to get back, Neil, into what you said, which is if we do a test, well, then what? How are we going to use the test? If you're not in a setting where you have access to DMTs, disease modifying and now infusion therapies, only for Alzheimer's, then why do you want to test? Sometimes, let me give a quick example and then I'll turn it back to you. I was talking to a colleague the other day, a neurologist, whose patient in front of her clearly had dementia of the Alzheimer type. The patient had dense lack of insight into her condition. Her family was very concerned, and the issue was now the conflict between the patient and the family around they're telling her, but mom, you have Alzheimer's disease. And she's saying, I'm fine. I'm living alone. I mean, I'm great. So in this case, the patient was unwilling to go through further diagnostic testing, but she was willing to have a blood test. And so the blood test came back positive, Alzheimer biomarkers. She was able to say to the family, yes, I agree with you, but let's not push the issue with mom right now. We can talk later about whether or not she would like to try some therapy. But for now, you're right. I'm validating your observations. But what's most important is the relationship between you and your mom. And you not enter into a conflictual or sustain a conflictual pattern of relationship. Let's talk about what we can do to make sure your mom is safe, happy, and healthy.
Right. So, but Sue, so here in that case, what the biomarker was like the definitive, so sometimes we would say the NPath, right? The neuropath is the definitive diagnosis when working in the field. But now this biomarker for this family was the definitive. But suppose
she was clearly affected. She clearly had Alzheimer type dementia. It was obvious. Right.
And so it's being used in that context, right? It's being used now. So just suppose, Sid, you've mentioned a case before where you have a person who can't go through cog testing, and yet it's being used now as, okay, it's going to be difficult to get cognitive testing done for a variety of reasons, language, et cetera, literacy. And so now we're just going to get the biomarker done, right? So if you can speak to that, and then Chi, I want to hear your thoughts on, with our communities that are diverse, what are some of the concerns we're having? And then now what? And they're very big, they're very large, and I'm very concerned about this. If that. So Sid, why don't we talk about the patient the testing issue?
Yeah. I mean, we had someone come in, clearly Alzheimer's, memory loss, verbal fluency, etc. Not as advanced. However, goes through everything, and we did get a PET scan, amyloid negative. And so this, blood test positive, amyloid negative. And so we're looking at this going, okay, this is something that looks like Alzheimer's disease, but is not. And this is someone who would have been at tremendous risk to put on some sort of DMT because of vascular burden and vascular disease. So, my concerns and this is in alignment with what Sue said, is, we need to remember these are people sitting in front of us. These are not biomarkers and these are not profiles. These are real people with real diseases that our responsibility is to help. And we don't have a comprehensive picture because, as Sue said, tons of people have amyloid in the brain, never have dementia. Happens regularly. We also have people, though, who have classic Alzheimer's symptoms who are amyloid negative. And so we need to truly understand these things because there are real risks from these drugs. And so it's how do we put people where on that, like you said, what's that journey to make sure we're reducing the risk as much as we can. And we're also keeping in mind this is a person with a family that we need to maintain family relationships. We need to maintain that love and that bond because we want to maintain that throughout this journey. And so, the patient that we had, she was really mad. She got really mad. Yet her primary care, as we talked before, our primary care doc did the single best Alzheimer's workup I've ever seen, and made clinically the right decision based on what was there. And so, it's just not as simple as people think. Alzheimer's is not one thing. There's a whole bunch of pathologies that can cause memory loss, that can cause depression, diabetes, vascular, and that's one reason why I love the notion of a blood test for rule out, because now those primary care docs can go, okay, wait a minute, not Alzheimer's. Let me look at these other things. There's other things that I can do something with. And so it's not always clear cut. And like I said, these are people. These aren't biomarkers.
Yeah, Chi, what do you think about, these situations?
Oh my goodness. I mean, it's incredible that this is completely unrehearsed just because I'm taking points from Sid and Sue that fits so well with my thinking about this topic. So the majority of my research is done in majority world populations, but of course also underserved and underrepresented communities. And so it's very interesting that even from our findings, when we look back at the drivers of incident dementia, most of them are really down to modifiable lifestyle factors. But even more importantly, I want to give an instance. So individuals of genetically determined African ancestry often, there's extensive evidence showing that they have lower prevalence of amyloid pathology. So like Sue did, let's take a step back to what these biomarkers we're talking about are measuring. They're detecting brain amyloid pathology levels as usually. And so, of course, if you have someone of African ancestry in front of you, high likelihood of dementia, most likely experiencing higher rates of multimorbidity, including vascular conditions, right? They're testing amyloid negative. What do? Do you send them home? They're more likely to develop, to progress and accelerated progression as well. So for me, it's insane to just only look at biomarkers and allow that to determine clinical outcomes and management outcomes. We need to adopt a more holistic view by, kind of like integrating patient histories and even neuroimaging, but also considering unique health profiles and also thinking about environmental factors that affect different populations. For instance, there are so many, there's data coming out of Latin America now showing that multidimensional poverty, for instance, is one of the biggest drivers of cognitive impairment. So when you, my colleague Michelle Mielke has also published on the impact of discrimination on blood AD biomarkers and of course comorbidities. So we really need to adopt this more holistic, I think, approach towards integrating all of these different measures when thinking about the diagnostic workup, but also how we interpret the results from the diagnostic workup.
Yeah, no, and I think you're bringing up a really good point. And I just like to put a plug into patients and families. Please do not underestimate their knowledge of these issues that is affecting their daily lives. They come to us routinely and say, well, Dr. A, what about this? This is in my environment. Dr. A, what are some of these social determinants that I hear about? How is that impacting this test result? Is this test result reliable? And I really want to stress this because, as Sid, you made a point, We are here to do no harm. Sue, you've said that before. Ultimately, do no harm. And yet, if we don't address these issues of how are these markers impacted by all these conditions, you lose trust with the person in front of you, their family, and frankly, you're going to lose trust with the primary care who are really being asked to do things. And it's like, well, now what? Again, now what? I'm in this mess and you haven't educated us effectively. We haven't talked about this in a process. And that is my biggest concern, that the whole thing together holistically is headed in a wrong direction if it becomes like this is the definitive test, right?
Can I speak to the issue of the primary care clinician and the aspect of what is primary care about and why do we care about dementia in primary care? Fundamentally, we care about dementia in primary care, regardless of its etiology, because it causes suffering, right? And the primary goal, the first goal, the always goal of clinical medicine is to heal the sufferer. And so to focus on the suffering as the experience of disease, and then to focus on the disease as an entity that is underlying this and contributing to it, but is not the sum total of the suffering. So when we think about what we can do for people who have cognitive decline, we can do a lot. We can help people with many kinds of interventions that have nothing to do with direct attack on brain pathology. And we forget that. We forget it because our health systems aren't really well designed to provide that kind of multidimensional care for people. The introduction of the guide model as a test, as a trial under the CMS Innovation Center, that's an important innovation, but we can already be doing a lot of this kind of multidimensional care for patients with appropriate linkages. So I think it's easy to get too narrow in thinking about, treating disease is what we do for patients. So that's only a piece of what we do. Then the other part about the influences on brain pathology, every day there are important new publications about how one or another factor in a person's lifetime, their lifetime exposure is manifested now in late life in brain dysfunction. And so if we want to, let's say we filter the air and reduce particulate pollution for somebody who currently has positive Alzheimer biomarkers and say MCI, is that going to change the trajectory of their disease? We don't have answers to that. So we're really up against a burgeoning database that is getting more and more complicated as it gets richer and richer. And I think we should be humble in the face of this and really see that the place of biomarker testing is quite specific.
Well said, Sue.
Yeah, no, very well said. And that leads right into the context of use. Sid, you use this quite a bit, and I really like the term. The context of use is really important because, frankly, that is medicine. We work by algorithms all the time. Sue, you mentioned cardiology and, there are risk calculators. And I would like to also highlight patients are used to that kind of thing. They go in and they know if you check this, you get 1 point for this, you get 1 point, you're at a risk for, let's say, heart attack. You are at risk for having a stroke. And the physicians and fields like that look at these calculators modify their treatments based on those calculators. So you're right. We are nowhere near that right now. True. But Sid, the context of use of where in our algorithms, protocols, workups, where should we go with this right now?
This is something obviously, I feel very strongly about. And actually, because of the advances in the field and how good the tests are now, I think previously we may not have even been at a good place to define the context of use. And, I think one of the problems that we run into, because I see this in my community talks all the time, is the way the headlines are talking about these blood tests is, oh, this one blood test does everything. It tells you you're at risk. It tells you you have the disease. If you're going on a drug treatment, it's going to. That's not how medicine works. And oftentimes, in most diseases, there's a multi-tiered stage diagnostic screening approach, right? You do a rule out and a second level for that intermediate. Then you do maybe a confirmatory. Normally, a true disease detection takes at least 3 tests, not 1, not 2. And so that context of use is, to me, so important, because then we can explain to that primary care doctor, what does this actually mean? We can explain, if anyone has kids, they got the heel stick with the baby, they do this, and almost everyone has a screen positive on something because they screen for so many things. Well, then as a parent, you're terrified over the weekend or waiting. But when this happened with me, the doc was able to sit, and I understood context. If you sit, look, you're probably going to get a phone call because so many things, there's so many false positives. Or we can sit with our patients and say, hey, look, if this comes back negative, you do not have PSA. If it's negative, you don't have prostate cancer. And so we can put it in that context. In that way, the docs can tell the patients, it came from a primary care doc. If I had a blood test that said no, an intermediate, if I knew ahead of time that said, oh, I have a second test that's going to help out. So if it comes back intermediate, we're going to do this one. It's going to clarify it. We can outline that journey and reduce the stress. I mean, the number one fear of our patients is dementia. It's it. It's beyond cancer. It's beyond heart disease. That's the fear. And we can alleviate a lot of that and streamline the research dollars, expenditures, and get CMS FDA approval and reimbursement, all by very clearly defining the context of use. Sorry, I get that one. I get excited.
No, it's really important because it's a really important point. We have to be speaking in the language of our colleagues, and I think at times we forget this. We're going to put out something. They are working every day using these algorithms or these stepwise, do this, do this, do this. And that is one of the biggest things they ask from me. What are the things you need before, frankly, I hand it off? Before I hand it off to you. And I'm going through my head, this is what we'd like to see happen. I'm worried that the handoff, Sue, is coming right from the beginning. And I'm not even running down the field yet. It's like they're throwing the ball to me. And it's like, wait a minute, you didn't do all these steps, right? You didn't go through the play, if you will. So I want you to comment a little bit about, Sid, the context of use. How do you see this with all the work that you do? How do you see this with patients? Like, who should, in your opinion, not get these tests? And again, I'm doing the rule outs now. Who is the patient in your mind? I'm going to go around the grid here that you say, this patient shouldn't get it. This patient is coming in worried about, let's say, subjective memory, but everything is fine. My dad has Alzheimer's. Should they or shouldn't they?
Oh gosh. No, I'm thinking, but then interestingly, it's almost like, we talked. It was so interesting because it was a work group that lasted a year, and so many of these conversations and lots of frustrations, I should say, different opinions. But I'm gonna present the group's viewpoint, but also my viewpoint here. Yeah, and you ask a really relevant question, right? When you talk about who should get this blood test
and who shouldn't,
who shouldn't get this blood. No. Exactly. And you mentioned I think Sid's done an awesome job of defining the context of use, for the blood test in terms of, meeting specific diagnostic performance levels, right? In terms of their specificity and the sensitivity. So you have an awesome blood test then. So what next? I think, so for instance, someone, a Worrywell patient who has come into primary care, they haven't been objectively assessed for objective cognitive impairment. We don't recommend the use of the blood biomarkers in these populations because we think that all that just leads to is unnecessary anxiety and then potentially false reassurance, because most likely if they have family history, they might even test positive, but then they don't have objective cognitive impairment. You know, they can live the rest of their life without developing dementia. Do you put them on a DMT just because they think, you know, they're worried about having dementia? That wouldn't be ethical, first of all. But then we do think for, you know, for patients who are showing signs of cognitive decline, they're coming in with memory issues and difficulties. They, you know, they have difficulties in IADL, for instance. We think that blood biomarkers could be useful both at primary and secondary care settings. And I think, you know, for instance, I mentioned in this context, they could help rule out, you know, the non-AD etiologies before then proceeding with further diagnostic evaluations. So in our paper, we actually define where they could be integrated within the diagnostic workup. But again, I mentioned it's for people with objectively confirmed cognitive impairment or concerning symptoms rather than those that don't have, you know, objectively confirmed symptoms. And we think that they could go hand in hand. So once somebody is coming for done a clinical history, they've had tests, you know, to rule out reversible causes, then we think it could actually be utilized for triaging people towards the confirmatory testing and for further diagnostic evaluations.
Okay, so with that, Sue, I'm going to tip it to you now. What do you think in these cases? Who gets and who should? Let's say.
Well, I certainly agree with your formulation, but I also think, should anybody have a biomarker test if they are not going to have access to a treatment that depends on the presence of a pathology? And I don't think, I think that's a concern. Willy-nilly testing, when mostly what I'm hearing is that even community neurologists are who see people with Alzheimer's disease are not able or willing to mount a DMT infusion program. And so they're increasingly funneling their patients to the academic centers where protocols are up and running, and the problem there is capacity. You know, in any given academic center, there's a capacity limitation. So I have real doubts about the value of doing biomarker testing if there is no access to treatment that depends on positivity.
Right. So I mean, and that comes into equity and disparities, and you know, thinking about lessening disparities. We talk about it all the time, and access to care. And you're bringing up a very, very important thing. And
wait, Nilam, can I just add something?
Yeah, Chi, go ahead.
Just because, you know, so I agree with you, Sue. However, I've just come from an awesome experience. It's something called Walking the Talk for Dementia. So I did the El Camino walk with, you know, people living with dementia, their care partners. And during that walk, we were all humans. And it didn't matter that somebody had a biologic definition of Alzheimer's or any other dementia. But these were people living with dementia who had to do the same work. Sometimes they had to hold me because I'm quite lazy. They were helping me. And so I complete that whole hierarchy of patient, clinician, or researcher, participant was completely debunked. And so I do think that there is, you know, the tests help to detect people at risk, and strategies, modifiable factors do show a difference. Because during that walk, we had physical exercise. There was loads of social interaction, and the testimonials that are coming out from the people living with dementia within that 1 week period of having so much fun and, you know, having agency over their own health outcomes within that short period. I mean, it was just incredible. So I think that, yes, we might not have a biologic, you know, therapeutic that works for everyone, but there are other modalities. People could start thinking about maybe taking a walk with family, maybe being more sociable. And we can start to recommend these, and, you know, strategies to sleep better. So
you think
those strategies.
This is the impetus to give them that extra push to make some of those lifestyle changes. Again, exactly. This kind of result. So Sid, what are your thoughts on that? That this could be, you know, that little push. Hey, this is what the test result. I'm going to change. And you've heard it before in clinical. I want to know, it was with genetic testing, right? I want to know my genetic testing because then I'm going to make these lifestyle changes. I want to go to Hawaii. I want to do this. And then I would always say, can you please go to Hawaii now without the genetic tests? I mean, but do you think what she is saying, what are your thoughts on that? It's an impetus to start looking at lifestyle modification.
Yeah, I mean, and again, I always go back to context of use, right? And so there are blood tests that are highly accurate at detecting pathology. Then there are also blood tests that are not, and they're more of blood tests for risk of, or do you have memory loss, right? So my concern for primary care docs is 18-minute average visit with anyone 65 and above. So primary care docs don't even have access to testing for cognitive assessments. And so my work with primary care, one context of use is a screening test, blood test that says risk for just broad-based dementia, memory, not a specific pathology. That then tells the primary care doc, hey, when they come in the next visit, I'm going to spend 10 minutes doing a cognitive assessment, right? So it expedites the process. And the thing about it also is then, all right, screen positive. Now you have all these things you can consider: exercise, sleep, diet, context of use, right? One of the questions that Sue brings up that resonates very strongly is, what's the question, right? And so sometimes the discussion with the doc is, we just want to know, I just want to know what's going on with mom. And if I don't have a therapy, that's fine. But we all want to know. Okay, then it's a negotiation and discussion. These are people. They're not test results. And so I think it depends on the context of use. I do have concerns that Sue brought up about an amyloid screen. You know you're amyloid positive and you don't have access to an amyloid therapy. But the caveat is what we just discussed that she brought up, is if I don't have access to therapy. So the doc needs to be able to articulate that because some of these gaps have gotten worse, not better.
Right. And it does come back. It's a boomerang. It does come back to you. Well, why did you even do this if you know, or if I'm in a certain situation where I can't get this or there is no access? And it does come up. I'm sure you hear it in the community talks when people say, why would you do that if you know that down here we don't have that, or we don't have the resources, or we don't have the financial transportation to come up for some of these therapies? So one question,
can I add
yeah,
something to this? So what's coming to my mind is dementia-friendly America.
Right. Yeah.
And, I think that what we've heard is maybe having a positive blood test would act as a motivator. It's going to motivate a certain subgroup of people, but the lifestyle changes that we would like to see motivated in patients in general should start much earlier than any biomarker. They should start much earlier, and they should be public health interventions. They should be community-based interventions. So the study I want to see is I really want to test this idea of how motivating is a blood test for sustained behavior change. The truth is that people who are likely to be motivated by a test are likely to be motivated if a doctor says you got a problem. Or we don't know if we can prevent you from developing brain failure. Now, I never use that term with patients, but we're among friends here, right? And dementia means brain failure. That's what we're talking about, a failing brain, right? And so I don't know if I can prevent this for you, but I think in general, these things have been shown to be beneficial for your brain health. And so let's focus on brain health. So I'm not sure that a biomarker test per se has all that much motivating power when the lifestyle changes we're talking about have to be sustained day in and day out, month in and month out for years. And so we put a lot of energy into thinking about biology when our answers are still quite partial. We don't put enough energy into thinking about how do we change our communities to be more brain friendly. And I think both of us co-panelists here are very interested in that issue. Yeah.
But Sue, I mean, and I'll think about cardiovascular disease, right? How long have we been in the community to talk about know your numbers and get your blood pressure under control? And when you talk to people in the field, they're like, we are still dealing with high blood pressure, stroke. I mean, and I really think this is an honest conversation here. Okay. We are still at it with cardiovascular disease and stroke. and with so much community. And I'm not saying that there have not been strides, but my goodness, I still see in the community these pressures are out of control. Take your meds, know your numbers. And so again, what you're saying, these sustained, these sustained lifestyle changes to kind of track biological is going to be tough. But I do want to bring this question up before we finish up for today. So we've talked about these markers, right? And people are ordering them. And I'm always about the now what. Well, here's the thing. When do you reorder it? Oh boy. This is the thing. It's coming. It's coming. Oh, Dr. Agarwal, I don't trust that. I was in the middle of a treatment and I got that done. And I think that treatment, whatever it may be, is causing those markers not to be accurate. So I want to get this done again in 3 months. And so I'd like to just hear your thoughts on this in the clinical setting now, not research where we're, checking this under controlled situations, but in a clinical setting, how are we going to even approach how often these markers are going to be drawn? And again, the now what, when you get the result and the discussion, et cetera. So Sid, I'm starting off with you with context of use. How often are we thinking about reordering some of these tests?
The thing about these tests that from a dementia clinic standpoint, when I was in a memory clinic, if someone came in concerned, we ran through the whole workup, they were caught fine. Just 12 to 24 months. I don't want to see you unless something significantly changes. I have serious concerns that we're going to go, every 3 months, every 6 months. Look, neurodegenerative diseases move slowly. In the absence of some major event, biologically, something that the family feels a huge change has happened, I do not think we should be doing this more than 12 months. I think anything shorter than 12 months could be a problem. Because I think what we're not doing at that point, because one of the best things about a context of use of a rule out is lowering anxiety, reducing patient burden, family burden, medical cost. And so I think that's something that as a medical field, we have to educate the community on that. That is not the community coming back saying, I want it again, I want it again, I want it again. That becomes a very slippery slope, and in my opinion, a dangerous one, because the more times you roll the dice, the more times you get a false positive.
And we know with certain comorbid medical conditions, these markers are not accurate. And,
exactly.
and just in that setting, forget about reordering, right?
Absolutely.
Or with, kidney disease and cancer. I mean, we are still learning. So, Sue, I'm going to pop to you about what happens when people saying, don't like that result. I'm going to, genetics, we knew it. You got it, right? But this is a whole different thing. This is like clinical labs, the way things are being presented. So what do you think, Sue, on this? How should we be thinking about it now and approaching this for people who want repetitive markers being drawn?
It's breaking my heart to hear that this is even a question, because I think it's just it's a false choice. It's absolutely a false choice. And I think that people who are demanding repetitive testing need psychiatrists. I mean, seriously, there's it's a fine line between sharing information about new discoveries and feeding the anxiety machine, especially for, I hear mostly from my primary care colleagues, I see too many worried well. Just like I saw too many people with routine Alzheimer's that I didn't need to see as a specialist. They could have been easily diagnosed and managed within primary care. They didn't need my level of expertise. And so I think this is about managing expectations. So this whole I want this repeated test. I want to know whether is my level down now or was it too high? This is a non-issue that we should uncreate. To the extent that we have created this issue, we need to back away from it.
Right. Because again, it's as you said, and this is how it's come up. I'm now doing these things. Chi, I'm going to come to you. The lifestyle changes. Here we go. I'm doing these lifestyle changes, and I want to see how those markers have changed now. Are they better for me? So here again, people are taking it in their own hands And you're like, oh my goodness. So Chi, what do you think on this?
So first of all, I want to address, one of Sue's comments around the utility of repeat testing. It just takes me back to even the fact that with pets, right, you have the gray zone or peri-threshold. And we have that for blood biomarkers. Absolutely. There's no absolute. Like, people can transition, people can change different, environmental factors, health factors can influence results. So I'm one of those that actually think there should be repeat comfort, like with the blood biomarkers. I don't think you could just take one test and then that's it, that defines a person. I do think that there may be need to at least repeat it annually to see if there's any changes, for instance, because particularly because of how little we know on the impacts and influences of these biomarkers. So to utilize them effectively clinically, I don't know that you could just, use it currently as like you'd use a brain biomarker test like PET or CSF. So I would be.
But who should pay for that? Who should pay for this repeat testing? This is research. Do I want Medicare dollars to pay for repeat testing because somebody wants a repeat test? I worry about this.
But then should you be using, if we're not certain about the effectiveness or the accuracy then of of the measures, then should we even be offering the blood test in the first place? Because, you could have somebody show, a negative, for instance, or an intermediate range, and unsure whether, the primary cause of their cognitive impairment is driven by, AD etiology. And in such scenarios, then do you leave them to progress without doing anything?
Well, what are you going to do about it? The point is, if you don't have DMTs, you're only going to be doing lifestyle advising, and most clinicians aren't tracking lifestyle uptake. Even if they think that these things are effective, they're not tracking to be sure if it's happening. And so I think that maybe there's a bit of a skew here that comes from, we've all been heavily embedded in academic environments in which we're used to thinking in terms of data. And when you move into the practice space, I think we have to have a different set of measures about how we value what we do. And this is kind of, for me, this is still the driving concept is, I don't want to be pushed around by my patients to order tests that I don't think are valuable to them. And so I think we need to do a lot more, to your point, Neelan, before, about how do we really think about what primary care can and should be doing? How do we know? We need to ask primary care docs what they want to do in this space. We know generally about primary care values, but I think we need to hone in a little bit more on what they feel is valuable to their patients and therefore to practice decisions that they make. And that's kind of what I want that to be a major take home for our listeners.
And exactly. And I think, I'd like to add to that. So we have a primary care perspective that needs to be at this table. And again, how are you working? I cannot stress this enough. To come in and to put things in place and you have no idea what their work environment is, how they operate, how they get through their days, the teams that they have to supervise, I think is going to be very reckless for this. And if anything, it will cause a lot of burnout, even more so than it's occurring. And guess what? Nothing's going to happen. So primary care needs to be at the table. Geriatricians need to be at the table. They also have a different workflow. They also have a very different settings, and we need to hear their thoughts. And then the last piece would be neurology, geriatric psychiatry. These are kind of the four groups that, in my mind, I don't know, Sid, if there are any other groups that come to play as being asked to order. Will you order this? Let's say a patient coming in or a family's asking. But they have to be here on how they work. And how does this make sense to you? And how do you view these things for recurrence of, reordering these tests? My concern is insurance down the road. If you're going to be applying for insurance, are they going to be looking at these test results? Are they going to be mining the data for this? We have it going on right now. We understand that. But I think these are some really key points. Yeah. So I think right now we are up for time. I'd just really like to really thank you all. I mean, it's so terrific talking to you in clinical, in a conversation about how we all think about things, because we need to have these conversations. We need to have these diverse opinions and trying to figure out how to do this. I'm happy, Chi, that you have you're working towards some guidelines, but again, guidelines and adoption are two different things, right? And I think I'd like to just thank, Us Against Alzheimer's really for putting on this terrific summit, and also for everyone attending today. We hope that you have found this conversation interesting, that you've learned things just as we all have. And thanks again for your attention.
Thank you, Dr. Agarwal, and to our entire panel. Up next at 3 o'clock Eastern, a special fireside chat with U.S. Senator Mark Warner. We'll see you then.
I'm old enough to remember when cancer was a word that wasn't said. I'm old enough to remember when a diagnosis of AIDS was a death sentence. Those things are manageable now. But people sort of treated Alzheimer's as part of getting old. It doesn't have to be that way, but we all have to fight to make that stop. One of the most important conversations you can have with your doctor, and that your doctor can have with you, is about your brain health. And it's a two-way street. Doctors need to bring it up with patients, and patients need to bring it up with their doctors. You don't talk to your doctor about your brain health, it's sort of like not talking to your doctor about your cholesterol or your blood pressure. You can't ignore these things. The key is starting the conversation.
Alzheimer's is not a normal part of aging. There are actually things we can do to reduce the risk, starting with understanding the risk factors, like poor nutrition, lack of sleep and exercise, and loneliness. Health and wellness professionals play an important role in helping people understand this. More than 6 million Americans live with Alzheimer's, and is projected to double by 2050, with women, African Americans, and Latino people being hit the hardest. But we don't have to accept that as fate. Through the Brain Health Academy, Us Against Alzheimer's is connecting the dots between physical and brain health and empowering people to take action. 6 online courses available live or recorded, along with continuing education credits free with registration. Learn from experts in the field with information backed by science. Hear practical ways you can implement the strategies learned, and gain insight from both patients and caregivers. Health and wellness professionals are among America's most trusted voices. Let's help prevent Alzheimer's together.
Once again, here's George Vredenberg.
Thank you, Senator Warner, for joining us today at the National Alzheimer's Summit. You've been such a champion in this space for so many years. We want to thank you for your support. And we'd really like to get your views on where we are today and where we are moving forward. So let's just start with, why does Alzheimer's get the kind of bipartisan support that it does in Congress? Because it is the case that virtually everything that's done in Alzheimer's is bipartisan.
Absolutely. And first of all, George, thank you. I think we all have personal stories. I know your personal story, and the fact of this wonderful organization, Us Against Alzheimer's, the difference you're all making. You know, my personal story is that my mom had it for 11 years. 9 years she didn't speak. My dad and my sister took care of her 24/7 as caregivers. We had a little bit of help on the weekends. And I saw what that did not only to my mom, but to my whole family. And all of us have stories like that. My partner on a lot of this Alzheimer's legislation is Susan Collins. And I'm proud to say we've got 2 bills going to the president right now around Alzheimer's in terms of reauthorization of the Alzheimer's Act, as well as trying to make sure the NIH continues to do an annual update of what our goals ought to be. And I think I remember Susan talking about her dad. So this notion, Alzheimer's doesn't know Democrat, Republican, doesn't know liberal, conservative, and it is a human crisis, but as I'm sure we'll get into it, it is also a financial crisis to our government if we can't grapple with this hugely devastating disease.
Well, we had, as you know, and as you've led on this, a goal of trying to prevent or treat Alzheimer's by 2025. We're about to come up to 2025. We've made some historic advances against that goal with now 2 disease-modifying drugs which slow down the progression of the disease. Those drugs are now in clinical trials in people who do not yet have symptoms, on the hypothesis that if we slow the disease down earlier in its course, we'll get a greater impact of these drugs. So that's been terrific. Progress has been terrific. Give me a little, blue sky kind of thing about what we ought to try and shoot for by 2035.
Well, again, progress has been terrific, and we've also been able, through your and other leadership as well, to find those genetic markers that indicate if you've got that propensity. And I think that's important as well. But I think as we think towards 2035, we need to think about prevention on a way that we may not ever get to 100% prevention, but if we can get to 70, 80, 90%, I think one of the areas that we could offer great upside as well, that may not be directly related to specific drug therapies against Alzheimer's, but we know that obesity, heart disease, tend towards exacerbating those traits. And as we've seen the kind of Ozempic revolution in terms of being able to potentially cut back on obesity, type 2 diabetes, I think that could also slow the onset of Alzheimer's. So I think we need to be bold because, again, you'll have the data better than I. If we don't, and with the aging of our population, just treatment of this disease, not just from the federal government standpoint, but from the human standpoint of the caregivers, could literally break the bank.
Well, you put your finger on exactly where I think we ought to go. We ought to intervene in midlife against those cardiometabolic conditions and the lifestyle factors that might reverse those. And the question about what policy the United States government might adopt in order to encourage more aggressive treatment or more aggressive efforts at cardiometabolic disease will, as you say, have an impact on future prevalence of the disease. So it's really smart. But what can the government do
Here's one of the things. I'm not sure this would be solely the role of the government. It might be kind of all of society. We think back about technology innovation in healthcare, whether it's new drugs, new procedures, my wearable device that monitors. We've not really measured technology improvements in healthcare in terms of lowering overall healthcare costs. I think we need to have a little better accountability. And, I am interested in not only kind of insurance rate adjustment if people lead healthier lifestyles. We've got now ability with metrics to help encourage better behavior. This is not some government, overdoing, but I do think we ought to provide rewards for people who do make those behavior modifications, and that may be in insurance rates, and because we've again got a lot more data now, and that's even before we see the whole advances of artificial intelligence in this field.
I think that's really smart. Again, the notion of using a whole of society approach, because the last round of this in the NAPA process, the National Alzheimer's Project Act process, was mostly government agency work, trying to get business involved. We have a business collaboration effort on how to increase the brain health of employees, both for anticipating, as you say, these cardiometabolic conditions, which may in fact reduce future prevalence, but also to encourage brain resilience, because one of the factors that actually will encourage improved brain performance is socialization at work. Your best friend is at work, you come to work, you do better. And some companies are now beginning to encourage their employees to get more active on school boards and more active in local community activities, because they know that that kind of capacity for socialization redounds to the capacity of employees to work together at work.
Absolutely. I think that is dead on. I also think maybe I'm sounding my age and a little old school. There are some jobs that may work better remote, but I think the vast majority of us do better in a setting where we have to interact in person with others. And I do think that socialization process we see time and again is so critical.
So you mentioned the burden on a family, not just on the individual with dementia. Indeed, at some stage, the individual with dementia really does not understand their world around them. But you described a family where there are at least two caregivers. So we have what we think maybe 50 million people in the world with dementia. That means 100 million people who are probably caregivers around the world, disproportionately impacted on low-income populations, disproportionately impacting women, both as caregivers and as victims. And so I'm curious as to what we might do. And you have been leader in this, in thinking through how to improve the caregiving workforce and the caregiving burden.
Well, we again, my family, I was able to support my family financially through that burden. I mean, my sister quit work full time. I think we need to do more. I think there's indications, for example, there's some small ball or mid-sized legislation we're looking at to say a caregiver, if they leave work to provide care, could still contribute to their IRA even though they're not employed. And if they go back to work, they might be able to make it up. I think we need to look at Medicare reimbursement in terms of caregivers around Alzheimer's. I think this is a field, and again, it's probably what brought most of the thousands of people who are watching this right now at your conference to the table, because they've lived firsthand and seen that experience. This ought to be something we should lean into. And there's some governmental policies, but I also think, again, greater collaboration with the business sector, where the level of more generous leave is something that all ought to be considered. This is not something we're going to solve by a government program alone.
It is interesting because other businesses we talk to describe brain health in terms not just of Alzheimer's or cardiometabolic conditions and the like, but also mental health, so that in fact greater investments and more frequent availability of mental health professionals to the employee base is proving to cause a reduction in overall health costs in business, because people who don't have mental health and stress and who deal with those problems are actually better performers at work. So it turns out that it has a redounding effect.
Double bottom line. And again, this is there was huge, horrible things that came out of COVID. The one good thing that came out of COVID was, I believe, we moved telehealth forward a decade. And one of the areas where I think, at least the data I've seen in terms of the outcomes on mental health, this may be a technique where telehealth can again be used much more actively. Those kind of consult sessions, can be done over Zoom, can be done, with some inpatient, but a lot more telehealth. We've got to make sure that we don't roll back those improvements. We also got to make sure that we recognize that getting broadband to the balance of all Americans, which we've promised in the infrastructure bill, becomes a reality, because even some communities still can't even access the telehealth capabilities, which include obviously mental health.
Are state licensure laws getting in the way of telehealth, and is there an ability to set some minimal standards of some sort? Or
that had traditionally been a problem, and then about medical professionals going beyond their state borders, we waived a lot of that during COVID, and it needs to be reviewed. A lot of that expires at the end of this calendar year. I think the vast majority of those bureaucracy removements ought to be maintained in terms of telehealth. And again, I think particularly on the mental health side, the data I've seen has been very, very positive.
I lost my thought here because you mentioned something that really struck me as a very smart idea, but I'll find it somewhere in the brain and come back to it. But let me ask you about Medicare solvency. You mentioned not just the social cost, the impact on families of the disease, but also the cost.
Right.
Cost to government, cost to families. So I'm curious, as a person who clearly is very focused on the solvency of Medicare and figuring out what we ought to do to make sure Medicare is there for a very long time.
Absolutely.
How do we deal with this?
Medicare and Social Security are probably the two most successful government programs that we've had in this country. And when I think back to Social Security, when it first was put in place, President Roosevelt promised we'd give folks a check if they hit 65, and at that point, average life expectancy in the 30s was about 57. So
a good deal.
It was a good deal, and we've got to be honest, and we've got to, particularly to younger people. A lot of people don't believe Social Security and Medicare will be there for them. I think we need to honor those commitments. That will mean we've got to look on the revenue side to make sure they are appropriately funded. It means things like on Social Security, I think raising the cap so that a greater percentage of your income pays into the Social Security Trust Fund, and that could be adjusted by annual basis. And we do, not to try to lower cost for the sake of cost lowering itself, but we need to try to find savings. And I continue to believe that the promises of technology and healthcare, there's not a procedure, drug, or device that isn't promising savings. We've not captured those on a systemic way. And I think going forward, as we go into the debate next year about the tax code, thinking about actually pushing technology, but making sure that we recoup some savings for the long-term health of Medicare is terribly important. And the same case on Social Security.
The striking thing about the investment you're making in Alzheimer's investments is a claim that made by Roy Blunt, not a claim, but an assertion. He calculated out what the increase in healthcare costs due to Alzheimer's were occurring in Medicare and Medicaid, and what that trajectory is based upon the aging of the population. And he saw that it was going to be equal to roughly the Defense Department by the early 2040s. And he said, we're investing a pittance against trying to save money against this. One of the challenges here is how to assure that if you make earlier and earlier interventions against this disease, the harder it is to justify those cost savings. You're going to get much more cost savings, but how do we track them? How do we have the discipline to make sure that what we're doing today to reduce the costs of this disease through earlier intervention is a cost that increases now, but we can assure that we can track the cost reductions?
And that is a challenge. The congressional scorekeeper, that Congressional Budget Office, doesn't do a great job on tracking these savings. But that shouldn't mean that we don't take this issue on, because, again, anyone who's experienced this disease, as we all have, knows that if we could have put that off even for a few years, or even in some cases months. And one of the reasons why some of the drug therapy I'm so encouraged by, has both a huge societal benefit, but also has a cost benefit.
Yeah, one last question. The thing I remembered was the mention of possibly extending family leave, so that in fact people who have to step out of the workforce in order to take care of a parent, not just a child, can get some sort of benefit and assistance from the government. I know that was part of Build Back Better.
I think the whole question of paid family leave, we're the only industrial country in the world that really doesn't have that. Mm-hmm. What's included or not would be a subject of a great deal of debate. But let's see if we can actually build that into the system. Because again, if you can provide that person that flexibility on leave, he or she then can come back to work, don't have to potentially quit. And I think about this on the macro basis, that means a stronger economy.
Absolutely.
And so, again, these things all come together. I know our time's about up, but I just want to thank you again. But I also want to thank all the folks who are engaged in this great organization. This is a battle we must win.
Absolutely. And we all thank you for your leadership on this and your great articulation and creativity in how to approach this problem. So thank you very much.
Thank you, George.
Thank you, George and Senator Warner. We'll take a short break, and when we return, our next panel will explore how best to embrace innovative technology while advancing brain health equity. That's coming up at 3:30 Eastern. Please stay with us for more of the 2024 National Alzheimer's Summit.
Hi, I'm Sean Taylor, a board member with Us Against Alzheimer's. My husband, Ray Howard Taylor III, will have, 37 years next month, and the love of my life. To see this man now starting this journey, it's heartbreaking. He's so big and handsome and took care of me. And I've had to learn to take care of myself, take care of our children. The majority of caregivers are women. It's staggering. And to make it a double whammy, we are also at the highest risk for Alzheimer's. What I'd love to say to all the caregivers out there and really emphasize is trust your gut. You know your person better than anyone else.
Are you worried about your memory and brain health? Do you have concerns about a loved one? Us Against Alzheimer's can help. Brain Guide is a free platform that provides you with knowledge and resources to take the best next steps in managing your own or a loved one's brain health. Brain Guide includes confidential memory questionnaires that can be taken over the phone or online in English or Spanish. If you have memory concerns for yourself or are noticing changes to your thinking or memory, you can take a self-administered questionnaire. If you have concerns about a loved one's memory, you can take a questionnaire for someone in your life that you see often. When you are done, we will send you tailored resources based on the answers you gave us. And you have the option to print a summary for your doctor. Brain Guide is not intended to diagnose or make treatment recommendations regarding Alzheimer's or any other disease. First steps can be tough, but just one small step now can help you take every step that follows with confidence. Visit mybrainguide.org or call 855-BRAIN-411 to learn more.
Alzheimer's and other dementias are underdiagnosed and often diagnosed late, particularly among women, Black people, and Latinos. At the same time, the latest treatments are most effective in the early course of the disease. This panel will explore how cutting-edge innovations, such as blood tests, digital cognitive assessments, and AI, can enhance detection and diagnosis rates for everyone, and answer the question, how can we ensure the advent of new diagnostic and AI-based tools for Alzheimer's disease address rather than widen those disparities? Susan Dentzer, CEO of America's Physician Group, kicks off our conversation.
Hello, and welcome to this panel discussion on Alzheimer's detection and diagnosis, embracing innovative technologies and advancing equity. I'm Susan Dentzer, President and Chief Executive Officer of America's Physician Groups, and very delighted to be the moderator of this excellent panel discussion today. As you've heard, Alzheimer's and other dementias are underdiagnosed, often diagnosed late, especially among women, Blacks, and Latinos. And at the same time, the latest treatments are most effective early in the course of disease. So this panel will explore how the cutting-edge innovations that we'll be talking about can improve detection and diagnosis rates for everyone. Some of those innovations that we'll be discussing include blood-based biomarker tests, so-called digital cognitive assessments, and the use of AI to guide appropriate care pathways. And in discussing them, as you've heard, we hope to address a critical question: how to ensure that new diagnostic and AI-based tools for Alzheimer's disease address disparities rather than widening them. I'm most pleased today to be joined by three distinguished panelists, and I'll introduce them briefly now. First, we're happy to be joined by Dustin Hammers, who's a PhD and a board-certified clinical neuropsychologist and associate professor in the Department of Neurology at Indiana University. Among his other distinctions, he's the lead neuropsychologist involved in the longitudinal early onset Alzheimer's disease study, or LEADS, funded by the National Institute on Aging. And he's also the principal investigator on the lifestyle interventions for the treatment of early onset AD disease, Alzheimer's disease study, or LIGHTS, also funded by the NIA and the Alzheimer's Association. His research is focused on characterizing cognitive decline in early onset AD and improving the diagnostic accuracy by evaluating diagnosis of cognitive decline and the presence of advanced Alzheimer's biomarkers. So, Dr. Hammer, welcome. It's wonderful to have you with us.
Thank you very much. It's really nice to be here.
Also, we're very happy to be joined by Chris Monsey, MD. He's the Chief Executive Officer and the co-founder of Viz.ai. That's a leader in AI-powered disease detection and care coordination. Today, the Viz.ai platform has 30 different care pathways, including that of Alzheimer's. And Viz.ai collaborates with 7 of the leading global pharmaceutical and medical device companies to improve access to life-saving treatments. Among the company's greatest distinctions, it was the first AI company to be granted reimbursement from the Centers for Medicare and Medicaid Services via the so-called New Technology Add-on Payment that was introduced in 2020. We'll hear from Dr. Monsey about how AI and workflow solutions can help guide patients to the appropriate treatments, and also help dementia specialists and neurology practices in diagnosing and qualifying patients for these new treatments, in addition to preparing patients for treatments and monitoring them appropriately. So, Dr. Monsey, welcome to you.
Thank you.
And finally, we're very happy to be joined by Irving Vega. He's a PhD and an associate professor in the Department of Translational Neuroscience at Michigan State University College of Human Medicine. His research focuses on molecular and biochemical mechanisms behind the accumulation of tau proteins in Alzheimer's disease and related dementias. He's going to be talking about the influence of disparities and ethnic and racial factors on understanding blood biomarkers and Alzheimer's disease. So again, Dr. Vega, welcome to you.
Well, hi, and thank you for having me.
Great to have you here as well. So, Dr. Hammer, we're going to go first to you. You've been leading a program to try to drive better detection and screening of Alzheimer's patients. Tell us about that.
Sure, Susan. One of the things that you mentioned at the very beginning was about the really low rates of detection of either cognitive difficulties or dementia for folks who have it when they go to their doctor. It's actually approximately only 8% of folks who have a condition related to cognitive or thinking difficulty that have been diagnosed. We all would like to think that the annual wellness visit would be able to catch a lot of this, but unfortunately, that's not the case. And we know that in addition to folks not being caught with having cognitive difficulties, those who are identified and are referred on to specialty care tend to be those who are more likely higher educated and Caucasian. So individuals from underrepresented groups very frequently are not making it to work with specialty neurologists or geriatricians. And even the individuals who do happen to make it to work with a specialist, including as a neuropsychologist like myself, we then typically will use cognitive measures that, while we are doing our best to have them be culturally, linguistically appropriate, they have all been developed in their originality to be administered and normed with individuals who are usually not from that underrepresented group. And so as a consequence, individuals who are from underrepresented groups are very likely to either not get a diagnosis or potentially not get the most accurate diagnosis. And so what we wanted to do, myself and I have a number of great colleagues who are working on this project with me at Indiana University, we wanted to bring cognitive assessments as early as possible to the most individuals possible. And we know that primary care is the touch point that is involved with most of our patients. And so what we did was we provided a study where we had 7 different sites within the Indiana University healthcare system, which Indiana University is the largest medical school in the United States. And so those 7 sites have a very large reach and catchment of individuals. So we looked at individuals, anyone who was coming into one of our clinics for any reason whatsoever, and in particular for not a cognitive or thinking concern reason. And if they were over the age of 65, we asked them if they wanted to take part in a brief cognitive screen that used what's called a digital cognitive assessment, or a cognitive or thinking assessment that is conducted. In fact, it was on a tablet. And so for ease of use. And so for those individuals who were interested, we then provided them with the tablet. They were able to take part in the cognitive assessment, and we were able to let them know at that time if they were entirely intact from a memory and thinking standpoint, if they had some questionable difficulty, or if they had some pretty notable difficulty. And for those individuals, then we would follow up with making sure that they were not having issues as a result of hearing loss, for example, or as a result of vision difficulty. And we would follow up with some very brief testing with an administrator to ensure that the information we were getting was accurate. And once those individuals, we were confident with those individuals of that the results were valid, we had the ability to offer them either to work with a provider that we're using the term a brain health navigator, which means this would either be someone who is a registered nurse or someone who is a social worker who was able to then work with them and get them in contact with specialty care services like a neurologist, like a geriatrician. We also had the ability to offer them the option of taking part in getting a blood-based biomarker, a blood test that would look at the levels of amyloid in their brain, which for those on the call who are not familiar, amyloid is one of the two primary drivers of Alzheimer's disease. And so that is what the basics of this study have been, and I'm sure I'll chat a little bit more about it over the next hour or so.
Well, before we go to the others, just a quick follow-up. What have you seen so far? How willing are some of the patients coming in to engage in this? And what have you seen in terms of increasing the levels of diagnosis? As you said earlier, only 8% being diagnosed. What do we know even on a preliminary basis based on your study about how much of an increase we can achieve?
Absolutely. So we, in the year that we have evaluated individuals, we have been able to identify approximately 2,300 folks we were able to administer to approximately 2,300 individuals. And that was around 20%, give or take, of the individuals who would have come into the clinic. And so there were a number of folks who were not interested in getting a cognitive evaluation because, again, they weren't thinking they were having difficulties and they weren't coming in for that. They may have just needed a refill on their blood pressure medication or something like that. So some individuals were not interested, and some providers were also potentially not really interested given the demands that they had and the amount of time that a provider may have to work with a patient. But of those individuals who we were able to assess, we ended up having approximately a rate of 50% of those folks who again, coming in not for a concern of cognitive or memory difficulties, 50% were identified as having questionable or confirmed cognitive difficulty on the cognitive screening measure that we gave. And so just based on those numbers alone, that is a large number of folks who we have been able to provide more information about their cognition or their thinking than they would have had in any other fashion. And certainly than they would have had in waiting 4 months, 6 months for specialty services.
So about a 6-fold increase right there in terms of the numbers you've been able to identify, at least to learn more about their level of cognitive impairment.
Absolutely, yes.
Yeah, really extraordinary. Well, thank you for that. This will be an excellent transition, Dr. Vega, to speak with you. As we've said, we have a growing amount of knowledge now about diagnosis via blood biomarkers, and you've been working to apply that knowledge to the special considerations of the Latino and Black communities in particular. So tell us more about that.
Thank you for that introduction and Dr. Hammer's information. To build on what you was said already, imagine having a blood test that you can go to a clinical laboratory and diagnose Alzheimer's disease. So we are very excited that there are molecules in the blood, in the plasma specifically, that are representative of the same molecules that are the pathological hallmarks of Alzheimer's disease, and those can be detected. Their abundance of these molecules can be detected. So in order to go to that gold standard in the diagnosis, we need to better understand how these molecules are actually present in different backgrounds, in particularly comparing white individuals versus Black versus Latinos. The data so far indicates that there are some differences between the different ethnic groups. For example, for Blacks, African Americans, depending on their genetics, the detection of these molecules may be a lower abundance than what is happening in whites. And when we look at the very scarce data that is available for the Latinos, depending on the comorbidities that they have, either diabetes, hypertension, or kidney dysfunction, those factors can also affect the detection of these molecules in the blood. So our goal is actually to further understand how these different factors that are either due to comorbidities, meaning diseases that the individual have, or the contextual factors, the social components that contribute to affect the detection of these molecules in the blood. So another gold standard is, to the point that Dr. Hammer mentioned before, is how early we can detect this. So we are actually looking at individuals that diagnostically have gone into mild cognitive impaired, the early stages before they transition, if they transition to dementia. So looking at those individuals, that would be a gold standard, because we can detect using a blood test early on before they transition to more severe cognitive impairments, and we can intervene in our early stages. But like I said, it's important for us to better understand how these biomarkers are detected depending on the ethnicity of the individuals. So in order to increase participation, which is one of the main problems that we're having, is participation in research. We are implementing this community academic partnership program, where we are going, instead of asking participants to go to our research facilities, we're actually partnering with community organizations and making those members in the community organization part of the research team. So, for example, we are in West Michigan, we are collaborating with the Hispanic Center of West Michigan to contribute to the recruitment and retention of those participants in the research. And then the clinical side, we're actually partnering with a community clinic, a Salta Health, who actually is going to be performing the neurological assessment. We are going to provide neuropsychologists, trained neuropsychologists, to do the neuropsychological testing in Spanish, and also in Spanish, and also drawing the blood right there at the community clinic. Because bringing the research into the community and recruiting individuals from those communities to be part of the research team will actually not only increase participation, but bring knowledge on how to assess cognitive impairment within the community, so that, for example, in the community clinic, they can pass that knowledge to the clinical side and actually be able to implement it to the people that visit the clinic. So we're actually amplifying what we can do, not only to increase participation, but bring that knowledge and those resources into the community. Moreover, by training those members of the community, we are actually expanding our diversity and representation in the research team, so that people in the community feel identified with those that are actually reaching out to them to participate, so that we can get information that then we can serve them, and translating research into a service process. Like Dr. Hammer mentioned, sometimes these participants, if they go into the clinic, they have to wait 4-6 months, maybe a year, for a cognitive assessment. By participating in the research, they already have access to cognitive assessment, neurological assessment, and blood work that they will need it to be waiting for that for a long time if they go into just reaching out to a specialist. So translating that research can be of service to the community is another way that we're trying to increase participation and getting knowledge on how these biomarkers can be measured depending on the ethnicity of the different groups, and actually make it more specific and more sensitive, so that at someday we can go to the pharmacy and get that test to measure whether we have a problem in the brain related to the pathology associated with Alzheimer's disease.
Which would be a real advancement in spreading diagnosis and detection of Alzheimer's and other dementias. I believe, Dr. Vega, you have a phrase. It's usually said research goes from, say, bench to bedside into the clinic. But you talk about bench to community. And this is obviously a stellar illustration of that approach.
Yes, definitely. We should go when we, especially for dementia and Alzheimer type dementia, there's a lot of things we can do to reduce the risk. And as we provide information and reduce the gap between knowledge and practice, we can probably eliminate some of that bedside and just keep the community from the bench to the community.
Great. Well, thank you so much for that. And Dr. Monsi, now we'll go to you and your work on applying the platform that you've developed at VizAI to increase access to Alzheimer's treatments and reduce the variability of treatment, which we know is pervasive across almost all conditions, but certainly it's true in the case of Alzheimer's. So tell us more about that work.
Yeah, and thank you, Dr. Hammer, Dr. Vega. I think Alzheimer's is a disease that we're going to see dramatic improvements on how we manage over the next decade. And we have to decide how quickly we improve things, right? Today, there's about 6.7 million people in the US with Alzheimer's, but Dr. Hammer's work suggests that's dramatically underdiagnosed. Is it double that? Quite possibly. And then Dr. Vega's work to ensure that we have diagnosis through biomarkers is in its infancy. And so we've now got treatments that are starting to show efficacy, which is fantastic. So how do we accelerate that time from bench to community? I think that's what all four of us here are really interested in doing, and I'm sure the audience as well. My background is clinical. I'm a neurosurgeon, and we have a software platform that uses AI to identify disease and organize workflow. What we've heard today is that one of the biggest problems with Alzheimer's is care coordination and managing those patients. In certain university systems, I think Indiana University and Michigan, you're doing a fantastic job. But certainly across the entire population, the management is not consistent. We haven't yet worked out exactly what the best pathway should be, but also how do we standardize that across all communities across the United States? So what our software does is it uses technology to do that. I'll give you an example from another disease that we started working with in 2018. And another neurological disease, ischemic stroke. Strokes are when an artery in the brain is blocked. And unlike Alzheimer's, it's a very acute condition. And so when you have a stroke, every minute, 2 million brain cells are dying. And so these care coordination challenges that we're talking about that we see in Alzheimer's were very acutely felt in stroke. If you didn't get that patient to treatment to remove that clot, the patient would end up in a nursing home. If you did, the patient could walk out of hospital and go back to work. So we developed a AI platform that automatically reads the brain scan, detects the stroke, does measurements of what's called perfusion in the brain to see how serious the stroke is. And within around 60 seconds of that scan having happened, no matter where that patient has had that test, a community setting, a city setting, a center of excellence, or a center that doesn't have any neurological expertise, the system's able to send out an alert to the comprehensive stroke facility where the expert neurologists, neuroradiologists, neurosurgeons can read the imaging and make a decision to transfer and treat. And this software has been proven to reduce time to treatment by over an hour, which, if you think every minute is 2 million brain cells, translates to a big reduction in disability, about a year reduction in disability. Right now, we're working to try and do something similar in Alzheimer's, and it's in the very early stages. We want to work with Center of Excellence like Indiana and Michigan to try and understand what should the standard of care be for these patients. When should that cognitive assessment be performed? How do we detect a signal in that cognitive assessment, even though there's likely to be some variability in how it's administered, depending on the socioeconomic background of the person, as Dr. Hammer said. But how do we take signal and say, okay, this patient actually deserves further follow-up with a center of excellence, and try and streamline that workflow so those patients can get through to diagnosis and treatment much more effectively. The one thing of note of the treatments that we're seeing coming through, they're more effective if the patient is detected early. So just like in stroke, time is brain. Time really matters for these patients. So how do we reduce that time to diagnosis and therefore, if appropriate, treatment? And then how do we reduce the variability in care? So no matter which hospital you show up to, where you live, how much money you have in the bank or the color of your skin, you're able to get a consistent level of medical care and have a chance to get on the treatments that could improve your life significantly.
So you said your work is at early stages. What literally are you doing now as you try to build the knowledge and expertise? And particularly since this is an AI-based platform, you've got to assemble a lot of data to train your platform into how to make these judgments or offer these perspectives, I guess is a better way to state it. So what exactly are you doing at this point?
Yeah. So the positive news is the technology itself is mature in terms of detecting patterns in data, whether that's a brain scan or a cognitive assessment on the EHR. Right, the technology exists to be able to do that. We're also implemented broadly across the United States. We're in around 2,000 hospitals, where we already have that data flowing. The early stages, though, is working out exactly what you do. Like, what should the triggers be? Because you don't want to flood the clinics with patients who won't benefit from more advanced diagnostic tests and treatment. You want to get that right. So really where we are is working with centers of excellence to identify what should that workflow look like? What should the triggers be for, hey, detect the likelihood of dementia in a cognitive assessment. Maybe there's some sort of follow-up with imaging, detect patterns in the imaging, right? And then using that to trigger, hey, this patient should go to this clinic, this patient should have this follow-on test. We're working out exactly what that should look like.
So at this point, as you said, in the work with these various centers of excellence, you're still essentially gathering the data to try to understand how to train your system to offer these assessments? What exactly, how far along are you really at this point?
Yeah, it's really about, it's not necessarily the training the data, it's understanding what the workflow should look like. Okay. So we've had billions of images go through our platform, right? That's less of the challenge today. The challenge is, what should step A to B to C to D to E be that the experts agree should become standard of care? And how do you systematize that so it doesn't just work Indiana University, it works across the board, no matter where that patient's shown up?
And as you have made the point previously, as we mentioned earlier, there's so much variability in treatment across so many conditions. Are people starting to coalesce around what are the appropriate care pathways for patients?
I think Dr. Hammer's work and Dr. Vega's work is made an amazing start, but I think the answer is not quite yet. They're the experts on this. I think there's a group of physicians who are at the forefront of this, who are creating what that pathway should look like, but there's work to be done. I can see you both nodding, so tell me if that's correct.
Well, terrific. That's a great point at which we can broaden out this conversation again. Dr. Hammer, do you want to take up that question?
Absolutely. No, Dr. Mons, that's the way you phrased that was so good about the knowing what I know about deep learning computer techniques, about AI. It absolutely sounds like the technology you are using and the software you're using to make identifications has a long line of history there, and it's actually the people component of, once we have identified, then how are we going to get people to where they need to go within a very complex system?
Exactly.
And that is exactly one of the aspects that we have been working on, I will say struggling with. I think the entire United States and world is struggling with that as well. That once we've identified someone, then how can we get individuals the care they need as fast as we can? We are having similar questions. It's really a question of bandwidth in terms of when we use a cognitive screen, then how sensitive do we want that to be? Or how specific do we want that to be? If we make things too sensitive, then we have the risk of overloading an already very busy system. And then individuals who are being identified who may or may not have any difficulties are going to have to wait a much longer time than they would have even before. So it's that balance that is really challenging. And we are all, I think, trying to think of more creative ways to come up with this. So one of the main group that was behind a lot of the research that we are working on was the Davos Alzheimer's Collaborative, who had a main flagship program goal of bringing cognitive testing to primary care. And in that group, I mentioned we had the Brain Health Navigator. And that position is someone who has the ability to make sure that patients don't fall between the cracks from the time that they're identified to not only meeting with the specialist for the first time, but going through that process. Because unfortunately, in the larger medical system that we have, there usually is not someone specifically designed for that. The challenge we're having is making sure that processes are in place that individual can be paid, because obviously hospitals, some hospitals are capable of absorbing the costs for the individual providing that care, and others may not be able to. And so that's something that we have been trying to work with, and with the Davos Alzheimer's Collaborative, I know they are trying to work as well to making sure that these vital pieces of the puzzle, that kind of the glue that holds this process together, is able to occur.
I just couldn't agree more with that. I think you can actually think of our technology as trying to be a virtual brain health navigator, because it's connecting the dots between modules of healthcare that are working quite well but are just not connected, and so patients fall between the cracks.
Really extraordinary. So I wanted to just go back a bit to the question of early detection and screening, and the patients in particular. Dr. Hammer, whom you mentioned, you were successfully able to identify and screen, and as remarkable as we said, an 8-fold increase in that detection rate. You said something early on about how many of the tools that are now being used for these cognitive assessments, frankly, are skewed toward more white, more well-educated populations. Is part of the work unskewing those tools, or skewing those tools away from that inherent bias, or not?
Yeah, and it's also one of those things. At the moment that came out of my mouth, I thought, "Wow, I somewhat exaggerated that." But let me explain a little bit more. But you're absolutely right. So cognitive testing has historically been cognitive tests have been developed on not on underrepresented groups. And what we as a specialty and as a field over the last 30 years have been attempting to do is to make those tests more generalizable and more appropriate. And so what we do with cognitive testing, with formal testing that is a little different than just a 10-minute screen, would be look at how people are doing and then compare them to people who are their same age and level of education and other demographic, linguistic factors, those type of things. And so there's a lot of work that's going into making sure that we compare people to the right population group, even though the measures themselves may not have been originally created in that fashion. So I do feel that we as a field have come a long way with that. However, there is the reality that in some sites, for example, me personally, I do not speak Spanish. We have at Indiana University, we happen to have a neuropsychologist that does speak Spanish. But let's say a patient of mine comes in who is Spanish speaking, and my colleague is on vacation, or is for one reason or another is booked out many months. And that individual, I could work with them. I would need to use an interpreter in order to provide that evaluation. And the pros of doing that is it is a better evaluation than no evaluation. However, the con is we are having to have a third party try to literally translate what is being said in order to determine the cognitive capacity of this individual. And so, one of the ways that digital cognitive assessments, if done properly, one of their benefits is that these can be conducted in a way that has been, it can be delivered across a variety of languages. To the best attempts that we can to make them across a variety of cultures. There are some theories that no test is completely culture free. The act of having an assessment may be completely foreign to some cultures. But beyond that, if we can get the best we can with reducing the impact of linguistic factors, societal factors, cultural factors, then hopefully we can get a lot closer to getting a purer sense of the person's cognitive abilities.
Very impressive set of achievements that would be indeed. Thank you so much for that. So, Dr. Vega, I wanted to go back to you because you mentioned we're still in the early days of the science here, but that there may be factors related to comorbidities of patients who might present with cognitive issues that may make it less likely that we can detect the relevant blood biomarkers for Alzheimer's. What are the scientific hypotheses for that? If in fact there's some sort of masking that goes on because, as you mentioned, perhaps a patient has hypertension or some other condition, what would mask those blood biomarkers for Alzheimer's?
Yeah, I think for the audience, one way to illustrate, and I go to the community and try to use analogies so that these complex questions can be understood. Imagine you are in a forest and you are trying to look for an apple tree. As more trees are in that forest, the more difficult that finding that apple tree will be. So if we're looking at a peripheral fluid like it's blood, all the conditions that are in the different organs, from the brain to the liver to the kidney to the pancreas in diabetes, inflammation due to a chronic disease or even a stress, all those molecules are going to be increasing the trees in that forest. Well, we're still trying to find that apple tree in that forest. So how we can be able to, that matrix effects, which is the technical name used to describe that forest, how that matrix, which is the plasma and the complexity of the plasma, we can understand it better so that we can easily target those molecules that represent pathology in the brain. That can help us to differentiate between frontotemporal dementia and Alzheimer's disease. That can help us differentiate dementia with Lewy body from frontotemporal dementia from Alzheimer's disease. So how we can get to that? To the point that Dr. Hammers was mentioned before, in terms of how complex this is, from the neuropsychological point, from the molecular standpoint, it's also very difficult. If you look at our data, and Dr. Mansi mentioned how this is in the infancy, is because when we look at our data, we can, by a group, we can actually say that this group, this pathology marker, let's say phosphorylated tau, is increasing people with mild cognitive impairment or Alzheimer's disease. And then the normal of cognitive unimpaired individuals, they are here. And statistically, this is definitely different from this. However, you can see individuals in this level that are cognitive unimpaired, and you have individuals with cognitive impairment that are at this level. So they actually overlap. How we can differentiate that at the individual level? I always take this opportunity to push for something, and is that because of the variability and because of our individual uh, propensity or risk that we accumulate to our lives based on our lifestyles, based on our diet, based on our level of education, based on different factors. Each individual will have an X risk to develop cognitive impairment in the future. So it would be great if, as a standard of care, when we are in our 50s or 60s, we do a cognitive assessment or a blood and a blood test and a brain imaging. And next year, when you go to your study, to an annual visit, you do again the blood test and the cognitive assessment. And then in every 5 years, you do a brain imaging. And you accumulate that data so that you become your own norm. You become the same, your range of change is what we're going to dictate whether you are getting into cognitive impairment or not. Accumulating you as a baseline and then seeing your changes throughout the life, instead of trying to see these individuals that we are grouping it because they are white or because they are Latinos or because they're black, and they're using statistics to try to correct for age, education, sex, and all that. Statistics will definitely help us to understand complex data, but we cannot take a statistic to tell us what the biology is. So I think that in the future, if we can push the system to have, like we do it for men, we have a PSA at 45 or 50 years of age. We start doing the prostate specific antigen test. For females, is mammograms or biopsies, right? It's a standard of care. Why we don't do it to that individual, and then us scientists, we determine what is the range that needs to change in order for that individual to get a diagnosis.
Fascinating. And I guess in the remaining time we have left, we could take what all of you have said and put it together and try to paint a picture of what the world of Alzheimer's detection and treatment could look like a decade from now, as all of these tools and capabilities you've described really take hold and flourish and enable us to create that kind of longitudinal system where we are assessing brain health earlier in the lifespan. And as we know, Alzheimer's and other dementias have a long prodromal period. So it would be really great to start with a baseline earlier in life. And as you said, Dr. Vega, that would be standardized against each individual. And then we would see changes over time and be better able to develop the appropriate prescriptions for treatment, et cetera. And then Dr. Monsi, with regard to the capabilities you're developing, even better steer patients into the right care pathway. So let's imagine for a moment, each of you, I'd like you to take a couple of minutes to describe what that system could look like 10 years from now, if we get to the full fruits of harvesting the tools and technologies you've been describing. So Dr. Hammer, I'll start with you.
Certainly. One piece that we've alluded to, but we really haven't talked very much about, is the context of treatment for Alzheimer's disease right now. So after decades and decades and decades of hard work by the industry trying to identify disease-modifying treatments for Alzheimer's disease, we now have 2 drugs that are capable of reducing and removing amyloid, again, one of the primary players in Alzheimer's disease, reducing that in the brain, actually removing that in the brain. And those studies are showing that it is leading to a reduction in declines of cognitive difficulties for individuals. And so, I mean, with that phrase, what is it? Necessity is the mother of invention. We are living in a time where, instead of just theorizing about if we could identify earlier, then when we do have a treatment that will be able to improve X, Y, or Z. We are living in that exciting time right now. And it makes the need for these early detections with cognitive assessments, and I won't speak for Dr. Vega, but with blood-based biomarkers, and he'll be able to go into more detail. These aspects and the aspects with that and the aspects with AI in the medical record system to identify individuals who should be cognitively screened. All of those pieces together, I think it is absolutely necessary because we now have the tools to provide help. One of the major constraints that we had initially working with primary care about cognitive screening was the idea that, well, even if you identify folks, what can we do? And we heard that time and time again. And I'm very happy to say the more information we're getting about lecanemab, about donanemab, which are the two drugs that are disease-modifying treatments, that fortunately is going a bit by the wayside. And so I'll let others to theorize about their 10-year plan. I just wanted to say that starting out, that this is an exciting time.
And thank you for bringing up that extremely important context about developing and evolving effective treatments. So thank you for that. Okay, so again, just a quick minute or so, Dr. Vega, 10 years from now, how will what you're doing now look different because we will have made further evolution in science and clinical care?
Yeah, in terms of the blood biomarkers and using the analogy that I mentioned before, we hopefully gonna stop looking for just one apple tree, and we're gonna have apple trees and also blueberries and also strawberries, and we're gonna put that data together, and that's gonna give us a picture of what is happening in the brain. And we are actually now working to discover these other trees in that forest that could help us to narrow the diagnosis and increasing the specificity and the sensitivity to get to the diagnosis. And I think a lot of people are working on that, not only us, and we're going to get to that in 10 years. But using that information, I want to emphasize what I would like to see is people incorporating the individualized type of medicine where you get a data point of that individual at 50, at 60, at 70, and you use that data to look at the progression of that individual. That actually would be crucial if we can do it. Why? Because sometimes health insurance say, well, we don't have treatment. Well, as Dr. Hammer said, there are already something available. That's number one. Number two is that the data says, many studies said that we can, if we identify early, we can intervene, and that person, we can delay their progression toward full-blown dementia. Additionally, if we treat individuals at higher risk with hypertension, diabetes, hyperlipidemia, the statistic information says that we can cut almost 50% of the dementia cases in the world. So we have all that information. Let's start using it in an individualized way and in a real prevention so that we can reduce risk of the individuals who develop dementia. Absolutely. And finally, Dr. Monsi, just about a minute for you to tell us where you think capabilities you're developing now will be in 10 years.
Yeah, I think it's a great question because I think one of the takeaways probably from the panel today is we're in the early days of the clinical development of what we do with Alzheimer's patients. But I will note that in 10 years' time, 10 years ago, we had the first proper treatment for stroke, FDA cleared. And since then, we've had a big development in the technology, that treats the patients, big development in the technology that gets patients to the right place, and big development in how we treat these patients. You're in a 10x improvement in patients getting treated for stroke. And I think we're going to see the same thing in Alzheimer's. I also want to thank, Biogen, Eli Lilly, the pharma companies who've developed these treatments. They spent billions of dollars. What they've done, most importantly, though, is they've given a ray of hope for this disease and created a catalyst for work around Alzheimer's. And it's evidenced by the people on this panel. In 10 years' time, I think Dr. Hammer's work, yours and others, you will have established best practices for Alzheimer's. I think, Dr. Vega, in 10 years, you will have created biomarkers that can definitively define and potentially monitor the disease. And I think our work at VizAI, I think we will have this AI safety net that picks up this disease no matter where the patient is, and this AI navigator that makes sure they get to the right place. So I want to end with a sentiment of I feel very optimistic about where we'll be in 5-10 years' time from now.
Well, I think based on what the three of you have said, we have indeed a good deal of reason to be optimistic about these extraordinary advances in detection, screening, treatment, prevention, as you all have said as well, that really will create a very, very different world in the domain of brain health and dementia. So thank you again, all three of you, for delivering such a powerful and important picture of the progress made and much more to come. Thank you again.
A special thank you to Susan and all our panelists for this important discussion. Up next, George Vredenberg has a special conversation with Congressman Tom Cole.
Well, thank you for joining us this afternoon, Chairman Cole, now Chairman of the House Appropriations Committee, and a champion of investment in Alzheimer's research now for 10 years plus. So you have been really the foremost champion on the House side.
Well, thank you.
Over those years, working with Roy Blunt in the Senate.
Very close.
The two of you drove this whole effort starting back in 2010, 2012. So thank you for spending some time. A member of the Chickasaw tribe, first indigenous American in this position.
Yes, and as chairman of the Full Appropriations Committee.
So we will talk a little bit about making sure that we get these new drugs to everybody in the country, which is a bit of a challenge with the Native Americans. So we will come back to that. So I just want to understand. I think all of the people listening, this will be a couple thousand people that will listen to this. What is driving these investments? What's the thinking behind the increase in investments that you've been driving over the years?
Well, first, like is the case with so many Alzheimer's advocates, I had the opportunity to see this disease up close. I lost my father to Alzheimer's. We began to notice in '82 something was wrong, and by '84, we had a diagnosis. My mother's like a lot of caregivers. She wanted to keep Dad home as long as she could. She did. But by '88, it was dangerous for him and for her. And my brother and I had to do a sort of family intervention. And then we had to take my dad, who was a career military guy, to a veterans center and he spent the last 12 years of his life there in Alzheimer's units, actually in 2 different ones. And the last 11, honestly, didn't know any of us. So, I've seen what so many families go through. And I always swore if I had the opportunity to do something, we'd do something. When I got to Congress and had the opportunity to go on what's called the Labor, Health, and Human Services and Education Subcommittee, which has jurisdiction over the National Institutes of Health, I finally had my opportunity. And of course, partly by Alzheimer's advocacies and just interest and the great staff and working with the people out at NIH, Francis Collins was out there at that point. I learned it's our most expensive disease. So you could actually be for doing this. And, we spend close to $300 billion a year as a federal government looking after Alzheimer's patients. And of course, the projections are astronomical. If you could even delay the onset by about 5 years, you actually could save 42% of the money, not to even begin to count the human suffering and the tolls on families that this causes. So I thought, I'm in a position to finally do something. And Roy Blunt, a very good friend of mine, we were extremely close when he was in the House. He was chief whip on the Republican side. I was one of his deputies. We kept that working relationship. Matter of fact, I helped talk him into becoming labor age chairman over there. He was originally headed for agriculture. And so we had this partnership. But I thought a couple of things. One, if we can get at this and start making major investments, and back then we were spending about $500 million a year. And this is not just on Alzheimer's, but dementia. And
Right.
we're over $3.5 billion now. So we actually moved this up pretty dramatically in about a 7 or 8 year period. And we couldn't have done it, I must say, without Rosa DeLaura, who was my ranking member. That is the top Democrat on the committee when I was the Republican chair, and then we reversed roles 4 years later. And Patty Murray, who was now the chair of the full Appropriations Committee and working with Roy Blunt. So we actually, this was a common thing we shared. This is not a partisan type issue. Obviously, it doesn't affect people that way. But we all thought we have a unique opportunity here, and we have differences of opinion. There's lots of controversy in what's called the Labor Age Bill. It's the second largest spending bill after defense. But here's a place we can work together. And here's a place I could justify it, to my Republican colleagues. You got to make the investment here because look how much money you're spending. And if we make progress, you're going to ultimately do a lot of good and do a lot of savings. I always tell advocates when they go to visit people, I said, now when you go to a Democratic office, just tell them this is just the right thing to do. They'll bankrupt the country to do the right thing. I said, oh my gosh. And I said, when you go to the Republican office, tell them this is the smart thing to do. You'll save money. Oh my God. But, and so everybody's got a different appeal, but at the end of the day, the idea is to do both. These are really productive investments for us. And we're finally beginning to see, and it takes a while, money or the different drugs and things starting to come out that can lead to treatment. But I remember talking to Richard Hodis, was head of the institute that deals with Alzheimer's and dementia. Great guy, great scientist. And we did the first year, we increased, I think, research funding by about $300 million. It had been the largest increase in many years. And I called him up after we'd gotten it done and they'd had about a year. And I said, I know you probably can't answer this question, but can you tell me, did it make any difference? And he said, yeah, I can tell you right away, Congress. He said, research scientists are just like anybody else. They follow the money. And when you put that extra $300 million in, the number of applicants we got requesting research stuff went up by 28% in a single year. It's pretty dramatic. If you flag that this is important to the American people and we're willing to make an investment here, more science will come. I can't tell you which one of them will be a breakthrough or how it's going to work. I will just tell you, it's like anything else. The more activity that you're generating, then the more likelihood that we'll achieve something pretty fast. And the first sign is increased scientific focus and activity. So it was a good lesson, and we thought that was a good thing to continue.
When my wife passed away about 7 years ago, but she was a Democrat, I was a Republican. We used to go to offices and say we're the Alzheimer's party because the disease does not know Republicans or Democrats.
It certainly does.
And so we had one piece of paper that showed the increase in government cost against what we were spending against it. So it basically was stimulated by your thinking and Roy's thinking about how to present this issue. And it works with Democrats too.
It really does.
It does.
And again, you look for things, and strangely enough, in this bill where there are lots of things where, again, these are legitimate disagreements, but I never had anybody come to me. I always tell my Republican friends this. Nobody's ever come to me in a town hall meeting and said, you guys are spending entirely too much money on Alzheimer's research. Or, gee, why are you wasting all that money to find a cure for cancer? What? These are actually things the American people want us to take resources and invest in because they see in their daily lives with their family or their friends what the consequences are, and they want to do something about it. It's exactly the same thing that motivates them to get involved, in the advocacy organizations and to write checks and contribute dollars. And pretty important when you're writing your own check. Or, I went to an Alzheimer's dinner once. There were 1,500 people at it here in Washington, D.C., from every state in the union. And if you, at least the table I was at, and I suspect it was the same at the others, there were about the right proportions of Republicans and Democrats to elect, that would reflect the population. And you can, immediately tell this is just not something that's partisan. This is something that's personal, but they want the government to be involved because we have enormous resources and we can focus them in ways that'll make a difference. And most of them had either already lost somebody or had somebody that was probably unlikely to benefit from the research, but they didn't want other people to go through what their families had gone through.
We did some polling last year when there was a dispute about whether Medicare should cover these new drugs, and half of the American voters, which is about 75 million people, reported that they either knew somebody in their family or a close friend with this disease. 25% said they'd been caregivers, had been, or current caregivers of someone with Alzheimer's. So this is something the American people know in their gut, that's affected them. And to your point, they affect the family as well as the individual with the dementia. So,
well, I remember I actually used to be a pollster. I still own a piece of my old company. And we asked the question once, and people get interested in different diseases at different ages. Overall, cancer was always the number one because it was the most common. People over 50 were more concerned about Alzheimer's than they were about any other disease.
Yes.
And not that the other diseases aren't deadly and dangerous and awful, but they did not want to see people lose a sense of themselves and who they were. And again, they had a sort of innate sense of how difficult that would be as an individual and how awful it would be to watch somebody you love going through that kind of experience.
So you were central to the reauthorization of the National Alzheimer's Project Act, which occurred just a couple yesterday. So thank you for that, which extends this sort of notion of a national strategic investment in Alzheimer's to 2035. Curious, do you think you will continue to get the support of your colleagues?
I do. Again, strangely enough, this is, we're living through an incredibly partisan and polarizing era in Congress. It's an area where actually you can create a productive political alliance because it's not a partisan objective. And this is one of those situations where the rain falls on the just and the unjust alike. We all deal with these sorts of things. We all watch other people struggle. And I've actually found, legislatively, and I talk constantly with my friends on the other side, what are the several things we can agree in that we can move something forward? And this tends to be, biomedical research, without a doubt, probably Alzheimer's more than any other, particularly for people over 50, really does move the needle. And people sit down and try to think of ways to work together instead of why I can't work with this other people because they're hopelessly misguided about whatever they disagree on. And I found it's a good thing. It's not only productive, but it helps Congress work.
Well, one of the great challenges going forward, and where I think a good deal of emphasis is going to be in the next 10-year period, is assuring that we have the right diagnostic tools and treatment pathways for all Americans, because what most of the research has been done on white Caucasians and not in blacks or Latinos or indigenous Americans or Asians. And so one of the great challenges is making sure that we get these new medicines and the innovations that are coming to every American and not just those who are super able to pay or where the diagnostics and medicines don't work. So that is one of the goals that I hope we set for ourselves for 2035 as we think through the next 10-year goals, because you've done such a great job in getting us to 2025.
Well, happy to help. And again, a lot of people, have been part of that. But I would just encourage your viewers and listeners to remain active and go educate your members of Congress. Believe me, they want to hear from you, and this is something that you're going to get a good response on because you just hear about it and see it so much. And it's not something we need to fight on with one another on. It's something we can work together on.
Well, too much of America thinks there's nothing but fights in Washington, and there's so much that does happen on a bipartisan base that doesn't get the attention of the media. And this is one, and you've been a critical leader over the last dozen years on this. So, Mr. Chairman, thank you for your work, thank you for your championship, and thank you for carrying this forward.
Well, you're very kind to that. Thank you very much. Thanks for your advocacy. And we just, again, tell your viewers, don't give up. We're moving in the right direction. This is a time to hit the accelerator, not the brakes.
Absolutely right. Great note to end on. Thank you.
Bet.
Take care.
Thank you, George and Congressman Cole. Now, please welcome Russ Paulson, Chief Operating Officer of Us Against Alzheimer's.
It's time to hit the accelerator. Thank you, Representative Cole, for hitting the accelerator on Alzheimer's for the last several years and for saying it's time to keep hitting the accelerator. That research funding that Congress has provided for Alzheimer's research has made a huge difference in the field and in the lives of people. We're seeing that with these new medicines. We're seeing that with the blood tests that we talked about. We're also hearing some controversies around some of this, some things that have yet to be worked out. The hard science has made huge progress. We need to start working on the implementation science. We need to start working on how to get these innovations to people, no matter where you live, who your parents were, what you look like, how much money you make, who your doctor is. People need to have access to this stuff. And there's a lot more work to be done there. We need to hit the accelerator on the distribution of all this good stuff, even as we continue to improve the good stuff that's out there. You heard some controversy about some of this stuff, and that's great. That means that we have started the conversation. We started our conversation with a keynote address from our founder. Senator Klobuchar talked about her support for the field and her personal experience. And then we heard from Rebecca Chop, who is testimony to the fact that we're not quite there yet in how we treat patients. We need to work on that. We need to work on a clear pathway for patients. We need to work on a clear understanding of when it's appropriate to do what in this advance in our field. We need to start many, many conversations. I hope you found this conversation at the 2024 Us Against Alzheimer's National Alzheimer's Summit to be thought-provoking, inspiring, and motivation to keep your foot on the accelerator. We'll see you back next year. Thanks very much.